All right, everyone. Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Mohammed Alfuwais. I'm a third-year medical student, and thank you all for showing up today to my first PAL session. Inshallah, today I'll be covering a few things. It's going to be a very dense and heavy topic, but inshallah, I'll try my best to simplify this as much as I can. And it's going to be on the spinal cord and brainstem lesions. Now, you guys already finished everything that you need to know for your midterm. So this is going to be a quick recap on everything pretty much. So I'm going to be teaching you guys the basic anatomy, just a brief recap, because I already know you guys took a PAL session with Rafi and with Maryam Al-Tayyib, who already explained the basic anatomy of the spinal cord, of the brainstem, and stuff like that. So basically what I'm going to do today is link the basics of anatomy to the lesions, and how can you find the lesions, okay? The thing about neuro in terms of the type of questions you might be getting is that sometimes what he'll teach you, Dr. Yaqeen, and he'll assess you is where is the lesion. So this is what I'm going to tell you guys today and teach you guys how to localize where the lesion is, wherever you are in the brain, okay? Either in the brain, brainstem, or in the spinal cord, because it's very important that you know where you are in the central nervous system. So as I said, I'm going to be going over a quick anatomy review. I'm going to go over the spinal cord lesions. I'm going to have some questions for you guys just to test your knowledge. And then I'm going to go through the brainstem again, and then the brainstem lesions, inshallah, at the end. At any point, if you don't understand anything, please stop me, ask me questions. We'll make this as interactive as possible. And this is your chance. If you have any questions to any of these topics, please feel free to ask me. After it, if you have any more questions, you can ask me through my number or email, okay? So Bismillah, let's start. So you guys already took the spinal cord, and you already obviously know is that the spinal cord is divided into two parts. You have the gray matter, which is the central part over here, the butterfly-shaped thingy in the middle, and then the white matter, which is around it. Now, what is in the gray matter is the motor or the nuclei, okay? Whether it's sensory nuclei or it's motor nuclei. But it's divided into different horns or different segments based on what nuclei it carries. So if you look into here, you can see that this part over here is the more anterior part. This is going to be the anterior, okay? And this is going to be posterior. Okay, so looking at the anterior part over here, you will have the anterior horn or the ventral horn, okay? Now, what will the anterior horn or ventral horn have? It will have the motor nuclei, okay? So you need to remember that the motor nuclei, specifically the lower motor neurons, will originate from here, which is the anterior horn. Now you look into the posterior horn or the dorsal horn. The dorsal horn or the posterior horn, which is this part over here, will have sensory neurons, okay? So here you'll have sensory nuclei, such as the substantia gelatinosa. So these sensory nuclei, basically what they'll do is you'll have sensations coming from the body. It'll go to the dorsal root ganglion and then back into the spinal cord. Where will it go and synapse to? Mostly, for example, for pain and temperature, it will go to the posterior horn and synapse with the substantia gelatinosa. Then it will go up through different tracks. In some segments of the spinal cord, you actually have additional nuclei, and these are through the lateral horns. Now, these lateral horns or the intermediate horns are sympathetic, okay? So it'll contain sympathetic nuclei that will then ascend upwards with the spinal cord, goes to the brainstem, and it will control basically the sympathetic functions of the face, okay? So these are the basic structures of the gray matter of the spinal cord. Okay, all levels will be the same except the thoracic segments and some of the lumbar segments, which will have this, which is the lateral one. And you guys probably already know this already. Now, looking into the white matter, which is surrounding the gray matter, it'll be divided into different tracks. You need to know these three tracks perfectly, okay? Which is cortical spinal tract, spinothalamic tract, and dorsal column tract. You need to be perfect with this because localizing lesions will mostly depend on these three tracks specifically. So let's start. First thing is you have one descending tract, which means that's coming from the brain downwards, and that's containing fibers coming from your body. So it's going to contain signals that you want to feel from your body, for example, and it will go up the spinal cord. Where will it go to? It will go to the brain, okay? But obviously, go through different structures until it reaches the brain. So track, we'll start off with this, is going to be the motor tract. And this makes sense because if you want to initiate motor functions, it has to come from the brain at first. Then it goes to the spinal cord, then it goes to your muscles, okay, to initiate certain movements. So the descending tract is the cortical spinal tract. and it will have two order neurons. The first order neuron, which comes from the brain, from the primary motor cortex, it will go and descend all the way down to this area right here, and it will synapse with the anterior gray horn cells, okay? Which then will have a second order neuron, which will go all the way to the muscles, okay? So that's basically the cortical spinal tract. In terms of what happens if you have a lesion in the cortical spinal tract and stuff like that, I'll explain in a few slides from now. Now, the next tract, which will be the two ascending tracts. The first one I'll explain is the dorsal column tract. The dorsal column tract will basically carry certain sensations. These sensations will be the sensations of vibration, conscious proprioception, fine touch, and pressure. Now, how do you know if a patient or if someone has defects in the dorsal column in terms of how can you actually test for these things? Because you might tell you that I don't feel vibration, that's true. But what is conscious proprioception, for example? Conscious proprioception is that someone knows the position exactly. So Farah in the chat said Romberg test. Exactly. So you tell the patient to stand up and close their eyes. And then if you see that they're wobbling, for example, or they're unstable, that is a positive sign, which is the Romberg sign. And this tells you that's a defect in the dorsal column tract. Another way you can test it is if you tell the patient to close their eyes and you basically test their position of where their joints are, okay, where their finger is. So you basically close your eyes and then go up and down, and you tell the patient, okay, where is your finger? Is it up and down? And it'll tell you if it's up and down. If they can't tell you this, this is another sign of conscious proprioception defect. Unconscious proprioception is a function of the cerebellum. Okay, so this defect will lead to ataxia, for example, loss of coordination of movements. So for example, if you're trying to reach out for something, you won't be able to reach out to it. You'll either undershoot it or overshoot it. Okay, so that's the function of the cerebellum. For vibration, it's very simple. Get a tuning fork and basically put it on the patient's joints, and then you just feel sensations, either vibration or no vibration. No vibration, defect in the dorsal column. Now, what are the dorsal column tracts specifically? Is that you'll have two. You'll have the fasciculus gracilis and fasciculus cuneatus. If you look into here into this picture, you'll have that the fasciculus gracilis will be carrying fibers from the lower part of the body, okay? And it will ascend upwards. The fasciculus cuneatus will be carrying fibers or sensations from the upper part of the body. So then it will go all the way up to the level of the brainstem. And can someone tell me which level of the brainstem it will go up to and synapse with the nucleus? Medulla, good. So it will go to the lower medulla and it will synapse with two nuclei. The fasciculus gracilis will synapse with the nucleus gracilis. The fasciculus cuneatus will then synapse with the nucleus, okay, for the cuneatus. Then it will cross over. And because second order neurons will normally cross over to the opposite side, and it will continue ascending up as the median lemniscus, okay? And it will go all the way to the thalamus. In the thalamus, you guys did not take the thalamus yet, I don't think. That's a later topic. But basically, the thalamus will have different nucleus or nuclei. The ventral posterior lateral nucleus of the thalamus is where it will synapse. And the VPL is basically carrying all sensations from the body, okay? The VPM is for the face. Okay, just remember the face for VPM and then the body for VPL. Okay. Yeah, okay. You guys took it yesterday. All right, interesting. But basically, that's the thalamus in terms of the sensations that are coming from the body. Then it will go all the way from the thalamus, from the ventral posterior lateral nucleus in the thalamus as the third order neuron, all the way to the primary sensory cortex. Okay, so these are the three neurons in this case. The next tract, which will be the spinothalamic tract. Now, the spinothalamic tract will carry the sensations of pain, temperature, crude touch, and pressure. The two that you really need to focus on, remember, are pain and temperature, because that's usually what they'll give you in terms of the signs and symptoms in cases, for example, is that the patient lost pain and temperature. Now, if they lost pain and temperature, think spinothalamic tract. Now, the way that spinothalamic will work is that it's going to be really weird in the spinal cord because it's the only one that actually crosses over in the spinal cord. The rest, I know the corticospinal, the 15% will cross at each level, but that's not as significant as the spinothalamic. So the spinothalamic, after carrying sensation from the body, the first order neuron will come and synapse with the substantia gelatinosa. And when it synapses with the substantia gelatinosa, it will then, so for example, I'm going to actually draw this. You'll have a dorsal root ganglion. The first order neuron will come in and synapse with the substantia gelatinosa in the posterior gray horn. Then it will go, the second order neuron will cross over to the opposite side, which is the crossing over, and ascend upwards. to the contralateral side. Now, this fiber over here, which is the crossing over fiber, just remember the name of it. It's the anterior commissural fibers. This is important for a specific lesion of the spinal cord. I'll get to it later. And it will basically ascend upwards. So just as a concept, and I'll explain this when we get to the lesions, is that if you have anything that's affecting the level of the spinal cord, usually below the level of the lesion, you will have loss of pain and temperature in the contralateral side of the body. Everything else will be ipsilateral, okay? So I'll explain this in a later slide, more detail, and inshallah, it makes sense. So this corticospinal tract, the spinothalamic tract, the second order neuron, will go all the way to the same thing, which is a thalamus, the ventral posterior lateral. Synapse there, third order neuron will go then to the brain. So these are basically the tracks and the ascending tracks, the descending tracks and their roots. They're different, different order neurons and where it goes to. Now, this is just an overview of everything. For the corticospinal tract, something I want to mention is what is upper motor neuron and what is lower motor neuron. So the lower motor neurons are basically the nuclei, okay? So these are the nuclei either in the brainstem for the cranial nerves or in the anterior gray horn cells for the spinal cord, okay, for the muscle movements, for example. So the lower motor neurons will be located here, okay? So you'll have the nuclei, and then you'll have the nerve that's coming out of the brain, out of the spinal cord. Or you'll have, for example, the hypoglossal nucleus in the medulla, and then the hypoglossal nerve. That's, for example, a lower motor neuron. An upper motor neuron is basically the corticospinal tract and corticobulbar tract. The corticobulbar is basically the tract that's coming from the brain and going to the nuclei of the motor cranial nerves, such as the hypoglossal nerve. So that's the corticospinal, corticobulbar in terms of being an upper motor neuron. Now, what happens if you have an upper motor neuron lesion versus a lower motor neuron lesion? So let's go to this slide. So the function of a lower motor neuron, okay, is, for example, the reflexes, the deep tendon reflexes. Where you have, for example, if you basically hit a tendon, you'll have muscular contractions and so on and so forth. So I got a question. So a lesion of the spinal cord at the dorsal column is contra or ipsi. So a lesion at the level of the spinal cord at the dorsal column is usually ipsilateral. Either at the level of the lesion or below the level of the lesion, it will be at the same side, okay? The reason why is because the dorsal column, when it comes here, for example, I'm sorry, I'm jumping points, but pretty much is that you'll have, for example, this dorsal root ganglia. So you'll have sensation of vibration and conscious proprioception coming up. It will go here and basically ascend upwards with the dorsal column tract. It won't synapse at the level of the spinal cord. So you won't have a second order neuron at the level of the spinal cord at all. It's still the first order neuron until it reaches the medulla. Then it will synapse with the nucleus cuneatus or the nucleus gracilis. Then it will cross over and then will go up as a medial lemniscus. Being that anything that crosses over, anything on the opposite side will be contralateral loss of those. But since the dorsal column does not cross over at the level of the spinal cord, it will not have contralateral loss. It will be ipsilateral. Does that make sense? Okay, perfect. So going back to it, you'll have this. So the lower motor neuron, its function is basically to contract muscles, okay? So when it contracts muscle, basically, it will be functioning to control the muscle tone, okay? So it's usually more active. The upper motor neuron, its function is to regulate the lower motor neuron, because if you have a lower motor neuron that's functioning by itself, your muscle is going to keep contracting. So you need something to keep it in check. The reason is if you look up here in the cortex, you have a bunch of stuff going on here in this slide. And I'm very sorry that this slide is very messy. But pretty much, the concept of this is that the cortex, okay, the primary motor cortex, when it initiates a function, it's taking multiple different sensations. It's taking visual sensations. It's taking, okay, I want to move to a certain direction. I want it to be coordinated, so it will coordinate with the, the cerebellum and stuff like that. Then it will initiate a function. When you do certain movements, you have certain muscles that are contracting and relaxing, meaning that the corticospinal tract will basically regulate the lower motor neurons. So that being said, if the lower motor neuron is functioning on its own, being that the upper motor neuron is no longer functional, the lower motor neuron will keep functioning and it leads to muscular contractions. And it will lead to a spastic type of paralysis if you have an upper motor neuron lesion. Okay. Versus if you cut the lower motor neurons, which are the anterior gray horn cells, for example, if you have a damage there, basically you won't be able to innervate the muscles anymore. So with no innervation of the muscles, it will lead to flaccid type of paralysis. Exactly. So it will lead to a flaccid type of paralysis. And you have other signs with upper motor neuron versus lower motor neuron lesion, because, for example, if an upper motor neuron lesion, the lower motor neurons will fire. So you'll have spastic paralysis, hyperreflexia, hypertonia, and stuff like that. These signs. Another thing is Babinski sign. Okay, it'll have a positive Babinski sign, which is basically if you scrape the sole of the foot, the toes will contract and move upwards. This is normal only in one case, which is infants, babies, because of basically the tracts are not myelinated enough, I believe. So it will have a positive Babinski sign. It is not normal when you see it in adults. Okay, so when you see it in adults, you think of, okay, there's something wrong with the corticospinal tract, okay, an upper motor neuron lesion. The lower motor neuron lesion, you won't be able to innervate the muscles anymore. So that would lead to flaccid type of paralysis, hyporeflexia, hypotonia, and muscle fasciculations. Basically, because the muscles are no longer innervated, it will just start to spasm a bit, okay? But it's not the same as spastic type of paralysis, it's just twitching of the muscle since it's not innervated anymore, okay? Is this clear to you guys? Perfect. The next thing is this, which is basically the dorsal column tract and the spinothalamic tract. I went over this already, but I'll recap one more time before we start going into the lesions now. So the first thing is this blue tract, which is the dorsal column tract. Again, it will carry sensations of vibration, conscious proprioception, fine touch, and stuff like that. So to carry it, you'll have the first order neuron will go up the spinal cord through the basically through the fasciculus gracilis and cuneatus. And it'll go all the way up to the nucleus gracilis and nucleus cuneatus at the level of the lower medulla. And this picture, I know it's not, but just take my word for it. It is in the lower medulla. And then it will cross over. When it crosses over, it will then create the medial lemniscus. So then the medial lemniscus will go all the way up to the ventral-posterior lateral nucleus of the thalamus. Then it will go all the way to the primary somatosensory cortex, okay? Now the other one, which is the spinothalamic tract, which is carrying sensations of pain, temperature, crude touch, and pressure. So the first order neuron will go to the level of the spinal cord, synapse is there with the substantia gelatinosa, then will cross over as the anterior commissural fibers, then will ascend in the contralateral spinothalamic tract upwards. And it'll go all the way up to the level of the thalamus. It will synapse with the ventral posterior lateral nucleus. You'll get the third order neuron, which will go all the way up to the primary somatosensory cortex. So let's just say I'm going to cut, let's just say that just the dorsal column is on this side, okay, on the right side. So let's just say I cut this, okay. Can someone tell me where the patient would lose pain and temperature sensation? Pain and temperature. Contralateral. Okay, so if this is right and this is left, which side? Good. Perfect. Where would the patient lose vibration and conscious proprioception? Perfect. Good job. So that's the concept. Okay. Now we go to one more thing, which is the spinocerebellar and the cerebellar tract. The reason why I'm going to mention it here and now is because later on in the brainstem, it's one of the tracts that you need to just remember that it exists in the brainstem. The thing about the spinocerebellar tract is it's going to be carrying, unconscious proprioception, basically your positioning of your joints, for example, and it'll take it and all your, muscles, for example, and it'll take it all the way up to the level of the cerebellum. Now, the thing that this tract does, it will cross over twice, okay? The concept that I need you to just remember is that the spinocerebellar tract, if you have a lesion in the spinocerebellar or the cerebellum, it'll be ipsilateral, okay? That's the only thing that I need you to remember from this tract for now. Go into, when you study it, for example, for the midterm or the final, just look into what the function of the spinocerebellar tract. In the terms of the lesions, it's not as significant. Just remember it's ipsilateral, and just remember if you have a lesion in the spinocerebellar tract, you have ataxia, okay? You have ataxia and you have imbalance of the patient, okay? So that's pretty much it. Now we're gonna begin. Before I go to the lesions and go into everything, is there any questions? Perfect. So some terms I want you to remember before I get into each lesion, okay? So the first thing is monoplegia. Monoplegia is if you have a paralysis of one limb, okay? Being any limb, it doesn't matter which limb, if it's right arm, right upper limb, lower limb, whatever, okay? If it's monoplegia. Diplegia is if it's both upper or lower limbs. Paraplegia is paralysis of both lower limbs. Paraplegia, where would you see this more typically, is in the spinal cord lesions. Specifically, if you have, for example, a complete transection of the spinal cord. I'll explain what that is in the next slide, I think. Okay. Hemiplegia is if you have paralysis of one whole side of the body. This typically happens when you have, for example, a lesion in the brainstem, okay? Where you have one side of the brainstem is, whatever, infarcted, for example. This would lead to contralateral loss of or paralysis in the entire half of the body, okay? And versus whether or not you spare the face or not, that when we get to the brainstem, I'll explain when does it spare the face, when it does not. But basically, hemiplegia is one whole side of the body is paralyzed. Quadriplegia is paralysis of all four limbs, typically seen in the brainstem also. And one thing, one specific condition that it will have is the locked-in syndrome, and I'll get to what that is later on, okay? And that's pretty much it. Now, before I begin, I want to mention is that if you have, for example, a spastic type of paralysis affecting, for example, one limb, okay, one limb, whether it's upper or lower, and the lesion, for example, is in the right hemisphere, and it's affecting the left leg, think of a brain infarction, okay? If it's affecting, for example, only one limb, for example, and you have, for example, anything there, this is because of the homunculus. So think of that. If you have a spinal cord lesion, you'll have, for example, differences in the sensory versus motor. So sensory, in the contralateral side of the body, you'll have loss of pain and temperature. In the ipsilateral, you'll have vibration and proprioception loss. You'll have a spastic type of paralysis, okay? Okay, someone asked to repeat. Now, typically, with the brain infarctions versus brainstem versus spinal cord, the distribution of symptoms will vary, okay? And this is what you need to remember. If you have anything that affects the spinal cord, I'll start spinal cord, go up. So spinal cord, you will have differences in where the sensory versus motor loss is at. So at the level of the spinal cord, you'll have, for example, contralateral loss of pain and temperature. Then you'll have ipsilateral loss of vibration and proprioception, and you'll have ipsilateral spastic paralysis, okay? If it's at the level of the spinal cord. You move up to the brainstem, depending on where you are in the brainstem, because it will differ, and I'll explain why when we get to the brainstem, but usually you'll have one whole side of the body that will be spastic paralysis. One whole side of the body, the contralateral, will be loss of pain and temperature. One whole side of the body that will lead to, for example, loss of vibration and proprioception. What I'm saying is that everything will be contralateral when you get to the brainstem. When you go up to the cerebrum, it won't affect one whole side of the body at a time. It will have a different distribution. For example, the torso upwards or the torso downwards. The reason why is because of the homunculus, okay? So this is how you can differ different where you are in the tracks. Is that clear? Okay, I got a question. A spinal cord injury, dorsal ipsi, and corticospinal contra. Spinothalamic is contralateral. Corticospinal is the motor. Okay, so you'll have an upper motor neuron lesion, and this would lead to ipsilateral spastic paralysis below the level of the lesion. Is that clear? Yep, perfect. Okay, so now we go into complete versus incomplete spinal cord syndromes. So complete spinal cord syndromes is not, it's not that, usual or that you'll find this even when you get tested on this, because it's very simple. Everything below it will be lost, okay? Everything below will be lost. Basically, complete transection is everything at one level will be gone. So below it, you'll have bilateral loss of pain and temperature, bilateral loss of vibration proprioception, and bilateral spastic paralysis. At the level of the lesion, you'll have flaccid paralysis. Why? Because of the motor nuclei, okay? Below it, the corticospinal tract won't be able to descend downwards. So you'll have lower motor neurons will be functioning below it. So you'll have a spastic type of paralysis. So that's complete transection. None of the lesions that I'll explain will be a complete transection. Everything will be incomplete. With incomplete, it will affect certain areas of the spinal cord, depending on what the lesion is. And because of this, you'll have variables, different signs and symptoms that you'll have with the patient. Okay, it depends on what the tract is. Okay, so that's that. Now we get into the lesions. The most important lesion that you remember is Brown-Séquard syndrome. The reason why Brown-Séquard syndrome is super important is that this heavily assesses a question. How does spastic paralysis at the level of the lesion look like? Spastic paralysis does not happen at the level of the lesion. Because the reason is at the level of the lesion, you have basically the entire thing is gone. So you'll have the ventral horn, which will have the motor nuclei, which is lower motor neuron, will be there. So if you cut the lower motor neuron, you'll have flaccid type of paralysis at the level of the lesion. Below it, since the corticospinal tract won't be able to descend downwards and synapse with the motor nuclei below this lesion, it won't be able to innervate it. So you'll have an upper motor neuron type of lesion, and you'll have spastic paralysis. Oh, how it presents. So it presents with hypotonia, okay? You'll have hyporeflexia, which is basically you do a reflex and it won't be as strong. So you'll say in a case, for example, +1 reflex or 0 reflex. The normal is +2, okay? So it'll tell you that hyporeflexia. It'll tell you that there are muscle twitching, for example. It'll tell you that it's flaccid, okay? He won't be able to move it properly, okay? That's what a flaccid type of paralysis looks like. Is that good? Okay, perfect. So now for Brown-Séquard. I will draw this to make it much simpler for you guys, inshallah. So let's just say this is one level of the spinal cord, and this is another level. Let's just say this is T11, and this is T12. Now let's just say that we want to injure the T11. Okay, so I'm going to draw the gray matter now. Okay, so I'm gonna just do half, so it makes sense to you guys when I do this. And I want to cut, let's just say this is the right side, and this is the left side. I want to cut the left side. Okay, so left side of T11 is transected. Now we go over to one by one each tract. I'm gonna start with the easier ones, then we go into the more difficult ones. So let's just start with the corticospinal tract and what happens with the motor functions. So first thing, at the level of the lesion, since you have the motor nuclei is damaged at the level of the lesion. So what do you suspect to have at the level of the lesion? Flaccid or spastic type of paralysis? Good. Now, that's the level of the lesion. So let's just say the corticospinal tract is descending downwards. Will it be able to go all the way down to T12? Good. So that would lead to the lower motor neuron is still functioning. So because the lower motor neuron is still functional, what type of paralysis will you see below the level of the lesion? Spastic. Good. So that's the motor. At the level of the lesion, okay, you'll have a flaccid paralysis. Below the level of the lesion, you'll have a spastic paralysis. Okay, upper motor neuron below the level of the lesion, upper motor neuron lesion below the level of the lesion, and then lower motor neuron lesion at the same level. Okay, now that's this tract done. Let's move over to the next tract, which will be the dorsal column tract. Now, dorsal column, as I said, it will carry sensations of vibration and proprioception. So vibration and proprioception, let's just say coming from the left side of the body, you'll have this dorsal root ganglion, it's coming, and then it will go up. Will the dorsal root ganglion be able to go up? The dorsal column tract be able to go up? No, Because of the dorsal column tract not being able to go up below the level of the lesion, you'll have loss of vibration and proprioception, okay, conscious proprioception. At the same time, at the level of the lesion, since it's not going to be able to, sensation of vibration, proprioception won't be able to come into the level of the spinal cord, you won't have this, okay? So because of this, at the same level of the lesion, ipsilaterally, you'll have loss of vibration and proprioception, okay? So it will be ipsilateral all the way. So at the level of the lesion and below it, since there's no crossing over. Okay, good. Now the next thing, which is the hardest concept of the entire thing, which is what happens with the spinothalamic tract, because this one is the most confusing one and the one that most of us had difficulties understanding. So let's just say on this side of the body, on the left side, okay, you basically have a pin and you prick someone on the left side of the body. So let's just say, okay, sensations of pain will be going in and synapsing with the substantia gelatinosa on level of T12. Then, okay, the second order neuron through the anterior white commercial fibers will go to the opposite side and ascend upwards, okay? So now, looking at this, will the patient feel sensations from the left side of the body, yes or no? Yes. The reason why it can is because the tract can still ascend. Okay, the tract is still ascending. Since it crosses over from the left side of the body, it's going to ascend on the right side of the body above it. Okay, so because of this, you're still going to feel everything at the left side, below the level. Now, what happens at the level is that you have sensations coming from the left side of the body. Will it be able to synapse? Yes or no? No, because of this, you'll have ipsilateral loss of pain and temperature at the level of the lesion, okay? At the level of the lesion. Below it, we'll get to what happens. So now let's just say from the right side of the body at the level of T12, you do, again, prick test. So you have the dorsal ganglion, first order neuron will go to the substantia gelatinosa. Then it will cross over to the opposite side. Then it will try to ascend. Can it ascend if you have transection on the left side? No, exactly. So because of this, to recap the entire thing, on the level of the lesion, you'll have a flaccid type of paralysis with hypotonia, with hyporeflexia, okay, because of damage of the anterior motor nuclei, right here. Next thing is that you'll have ipsilateral loss of vibration and conscious proprioception and fine touch. And at the same time, you'll have ipsilateral loss of pain and temperature, okay? All sensations, everything will be ipsilateral at the level. And you'll have a flaccid type of paralysis. Looking below the lesion, you will have a upper motor neuron type of paralysis below the level of the lesion, but it's going to be ipsilateral. So you'll have ipsilateral spastic type of paralysis. You'll have ipsilateral hypertonia. You'll have ipsilateral hyperreflexia, okay? And you'll have a positive Babinski sign in the left foot, okay? The next thing is going to be what happens with the dorsal column tract. You'll have ipsilateral loss of conscious proprioception and ipsilateral loss of vibrations, okay? Sensations, since it won't be able to go down. And at the same time, go up from here. At the same time, from the right side of the body, okay, the spinothalamic carrying pain and temperature, it will go to the opposite side and ascend upwards, but it can't. Because of this, you'll have contralateral loss of pain and temperature, okay? Is this clear for everyone? Cool. One additional thing that I would like to mention is that this point right here, which is if it happens above T1, patient may present with ipsilateral Horner syndrome due to damage of the oculosympathetic pathway. Think of it as this, is above T1. Again, what did I say? Is that the gray matter will have an additional structure in the thoracic column and some of the lumbar, which is 1, 2, 3, I think, or 1 and 2. So it carries the lateral horns, which will have the sympathetic nuclei. Because of this, it will have to ascend upward. The pathways will ascend upwards through the oculosympathetic pathway. So if you have a lesion above T1, so in the cervical region, you will have ipsilateral Horner syndrome. What is Horner syndrome? What are the 3 findings in Horner syndrome? Ptosis, anhidrosis, and meiosis. Good. So basically, you'll have a patient, okay, on one side of the, on the left side, let's just say, let's stay consistent with this patient. So on the left side, if this is, for example, at the level of whatever, C6, okay? So you'll have ipsilateral, can't sweat, okay? Drooping of the eyelids, and the last thing is constriction of the pupils, okay? So that's the other findings you might see. This is above T1, okay? So this is basically the hardest lesion that you guys need to know, okay? It's the most important and the hardest lesion to know. Not really, but this is just a concept that you need to remember into why, there's no contralateral loss of pain and temperature at the same level of the lesion, but it's not too important, clinically important that you remember that. It's more important at the level of the lesion. Below it, it will be, contralateral. At the same level, it will be ipsilateral. That's all you really need to remember. The cases will be presenting like this, and the questions will be based on this. You don't need to remember that it crosses above. Okay, someone's asking, what would they ask the exact level of the lesion? No, they won't ask about the exact level of the lesion, but it's just for you to remember, because sometimes you'll have the sympathetic tract that's damaged, so you'll know that it's in the cervical region, okay? Would you recommend sketching what you just did or waste of time? I do recommend it. It's just for you to practice, because it makes you remember where the tracts are and where the lesions are. And can you repeat the syndrome again? Okay, so I'm going to go over just what you find, okay? Very quickly again. This is the lesion on the right side. So first thing is, let's go over what tract by tract. At the same level of the lesion, okay, you'll have loss of dorsal column tract. So you'll have ipsilateral loss of what sensations? Vibration and proprioception, conscious proprioception. Good. Then you'll have at the same level the ventral horn. So you'll have ipsilateral flaccid process at the level of the lesion. Then you'll have the spinothalamic, which will not be able to synapse over here. So you'll have ipsilateral loss of pain and temperature. So ipsilateral, everything at the same level. Below it, it will be different. So dorsal column, you'll have ipsilateral loss of conscious proprioception and vibration at the same level of below the lesion, ipsilaterally. You'll have spastic type of paralysis, an upper motor neuron lesion. Reason why is the cortical spinal tract will not be able to descend down. So the lower motor neurons will be more firing. And this will basically lead to spastic paralysis, hypertonia, hyperreflexia, a positive Babinski sign at the same ipsilaterally below the lesion. Okay. Last thing is spinothalamic tract. You'll have loss of pain, temperature, crude touch, and pressure contralaterally below the level of the lesion. Is that okay? Okay, perfect. So that's pretty much the hardest syndrome to remember, because it's the most tested in terms of concept, whether or not you got the concept of the brainstem. Now, a question: when does this usually happen? It usually happens due to trauma. So you have a guy who got stabbed, okay, in the back. That's usually how it's presenting. Another thing is tumors. Okay, so it can compress on one side of the spinal cord. That's just another reason why you might have this. It might help you to remember when it happens, because in the case it'll tell you a stab wound. So if you have a stab wound, just think of Brown's cord. So that's pretty much it. And I explained everything else pretty much. Now we go into more specific lesions. So the first thing I'm going to go over is poliomyelitis. Now, poliomyelitis, it's a virus. It's a viral infection. It's a single-stranded RNA virus. You don't need to remember that at all, but basically it will cause an infection. So the polio virus, it will have a predilection to the anterior gray horn cells in the spinal cord. So because of affecting the anterior gray horn cells, it will lead to a lower motor neuron lesion. This lower motor neuron lesion would present with what signs? Flaccid type of paralysis, hypotonia, and hyporeflexia. Okay. Now, since this is an infection, you need to remember that you'll have signs of infection. You'll have a fever. You'll have someone who's weak, for example, tired, malaise, headache, things like this. Signs of an infection. The other thing is you didn't take meningitis or encephalitis yet, but basically this is not meningitis or encephalitis. But you need to remember is that in the CSF, there's increased WBCs. Just remember that, okay? So what's important about this is you need to differentiate between polio and SMA, which is spinal muscular atrophy. The reason is because of the symmetrical versus asymmetrical weakness. Okay, where does it happen? So polio is a virus, so it will need to go and infect areas of the spinal cord, which is the anterior gray horn cells. Because of it going to affect the anterior gray horn cells, think of it as this: is that it will affect one area more than the other. The reason is because it will need to go to the area. So it might have a predilection to the right side more than the left side. Okay. Because of this, you'll have one side that's affected more than the other side. So you will have asymmetric weakness. Okay, so how does this present? Let's just say, if this is at the level of the cervical vertebra, and for example, let's just say it's affecting the brachial plexus, you need to, contract the arm, for example. So you'll have, for example, in the biceps reflex, you do it, you'll have it +1 in the right side, and then 0 on the left side. Okay, that's pretty much how it will show you. Can only one side be affected? Usually, no, it usually affects both sides, but one side will be affected more than the other. Okay. The next thing is the spinal muscular atrophy. This is the main difference between them, which is symmetrical versus asymmetrical. Another thing is polio is an infection. So you'll have infectious signs. So you'll have signs of infection, fever, malaise, headaches, and stuff like that. With spinal muscular atrophy, it's a congenital defect. So what happens is that you have a congenital degeneration of the anterior gray horns on both sides, and it will be equally. So you'll have both sides flaccid process. Okay. So that's pretty much that. And you might have tongue fasciculations as a way to help you hint it. The reason is it might affect the lower motor neurons in the, for example, the hypoglossal nerve. Okay, so it will lead to tongue atrophy as well. Okay, so that's why it might lead to tongue fasciculations. Fasciculations is again like mini contractions or spasms. It's not a spastic paralysis. It's just basically because it's deinnervated, the muscles will just contract a bit. Okay, that's it. And you might see it in a baby. So in the case, for example, you get it as a baby who has flaccid paralysis, floppy baby. That's basically how it's presenting. With polio, it's a child who's unvaccinated, gets this infection, asymmetrical weakness. With spinal muscular atrophy, a baby, it's a congenital defect. You have both sides equally. Okay, it's symmetrical. And basically, the whole thing is it's called Wernicke-Hoffmann disease. It's a genetic disorder. It's an autosomal recessive SMN1 mutation. You don't really need to get into details of this at all, okay, in terms of what this is. But you just need to know how to localize and find this lesion, okay? Are these two clear for you guys? Perfect. Okay, so next thing is amyotrophic lateral sclerosis, ALS. So ALS is a complete motor lesion, okay? It will be a mixed motor lesion. What do I mean is it will be an upper motor neuron lesion and a lower motor neuron lesion. The reason for this is basically it's a disease that causes increased inflammation of areas of the spinal cord, which will be the upper motor neuron and lower motor neuron. So this is because of a deficiency or a defect in superoxide dismutase 1, which will cause an increase in the reactive oxygen species, the free radicals, and this will cause inflammation of areas of the spinal cord, specifically the anterior gray horn cells and the cortical spinal tract. However, it will affect above the spinal cord as well. So it might affect the brainstem. Specifically, it might affect the cortical bulbar tracts, which is again the cortical spinal tract for the motor nuclei in the brainstem. And then it will affect also, for example, some of the nuclei in the brainstem. Specifically, the ones you need to remember are the nucleus ambiguus or even, for example, the hypoglossal nucleus. So with the nucleus ambiguus, it's the motor nuclei for the vagus nerve, for example. So you might have a patient who presents to you with dysphagia, okay? That's one of the signs of ALS. Now, the important thing that you need to remember with ALS is it's a mixed upper motor neuron and lower motor neuron lesion, but it affects different distribution. Every patient will be different. So, for example, in one side of the body, or not one side of the body, on one limb, you might have hyperreflexia, hypertonia. On the other side, you might have, for example, on the left lower leg, for example, or the left leg would be flaccid. Okay, that's how it's presenting. Another key thing is it's going to be a patient in their 40s, 50s, okay, and it's a progressive disease. You'll see that they have a worsening dysphagia. You'll see that they'll have hyperreflexia in one limb, and then you'll have flaccid process in the lower limb, stuff like this, okay? So it's a progressive disorder that will happen over time. And most oftenly, the reason why they die is due to respiratory failure because it affects the muscles that will innervate the diaphragm, for example. Okay, so that's pretty much how you can recognize ALS in a case. Okay, so that's pretty much that. Again, one thing you need to remember is sensory innervation or sensations will be normal. Every single sensation will be normal. Okay, so that's pretty much the ALS syndrome. Now, going into other ones, is it always bilateral? Now, again, it will present differently, okay? So you will have it affecting both sides of the body, but it will affect different things, okay? So you might have it affecting the anterior gray horn cells on the right side, but then the cortical spinal on the left side, okay? So it'll present differently. What you'll see is, again, a mixed disorder. So it will be an upper motor neuron and lower motor neuron. Look out in the question for progression of symptoms. Look out, for example, they will have in the lower limb, for example, a spastic paralysis, an upper limb flaccid paralysis. Differences in terms of where the symptoms are, okay? And again, no sensory defects, okay? Zero sensory defects. And the reason why I just switched the symptoms is because it varies. Okay, everyone's not the same, so it does not affect. It does not lead to flaccid paralysis in the lower limb and a spastic paralysis in the upper limb. It's not like this. It varies. Okay, it varies the distribution of symptoms. Okay, perfect. Now, central cord syndrome. I'll explain it on this diagram. So, the central cord. You need to remember what the central cord syndrome is: the surrounding structure to the center of the spinal cord. So, what this is, for example, you have the central canal. Okay, this is one type of central cord syndrome, or one etiology or factor for central cord syndrome, is you have this thing right here, which is a central cord. Now, in babies, you might have a specific malformation where you have a buildup of CSF in the central canal. This is called the KRE malformation type 1. You probably already had an embryo lecture on this, so go over that when you go into it. I'm not going to go into detail with this. But basically, you have a strings. The strings will grow, okay, over time. And it will basically lead to compression of structures surrounding the central canal. So these are, for example, what? The anterior gray horn cells and these spinal thalamic tract that's crossing over, which is the anterior white commissural fibers, okay? So because of this growing centrally and expanding basically in a circle, it will affect both sides. It will lead to, number one, bilateral loss of pain and temperature sensations, and bilateral flaccid paralysis. Okay, why is it flaccid paralysis? Because it's going to affect the anterior gray horn cells. So this is a lower motor neuron lesion. And why is it leading to bilateral pain and temperature sensation? Why is it not contralateral, unilateral, or ipsilateral, whatever? It's because the anterior white commissure, the spinal thalamic, will cross over from both sides, and it will lead to this tract over here. Okay, so since it's growing, it's going to affect both sides. So it will lead to these types of sensations. Now, what you need to remember is typically this will affect the upper part of the body and spare the sacrum. The reason is I'm going to go back to a very early slide and explain it on here. So if you look into this tract over here, you'll see is that the spinothalamic tract, even the cortical spinal tract, is that the cervical regions of the spinal cord are more medially located versus the lateral, which is going to be the sacrum. And the same thing for for example, spinothalamic tract. So because of this, it might spare the sacrum. And the same thing with distribution over here. So because of this, you'll spare the sacrum. So you'll have a patient who can't feel anything, who can't feel, for example, temperature. You'll have a patient who's cooking, for example, and has repeated burns, okay, in her hands. However, in the legs, it's normal. Okay, that's one type of way that you can tell that this is a central cord syndrome. And this happens in elderly post-trauma, for example, or post-whiplash injury, okay? The other condition, which is it's a congenital defect, it's KRE type 1 malformation. It leads to a syringomyelia, which will expand, okay? So that's pretty much it. Another way you can remember it is syringomyelia is going to happen more upwards, in the neck. So it'll affect the upper part of the body, not the lower. Okay, that's another way of remembering it. So just going over this, it's an injury to the central part, and again, just etiology. It's syringomyelia is one of them, very important one, and traumatic disc herniation or hyperextension injury, such as a whiplash injury. So a whiplash injury, it's seen more in, for example, if you have an elderly patient where it's a weak, for example, vertebral disc or weak bones. So you might have a compression and this would lead to anything in the center would basically be defected. So you'll have central cord syndrome. Now, the features, again, bilateral motor paresis, which would be a flaccid paralysis because it affects the anterior gray horn cells. Variable sensory impairment, typically it will be a loss of bilateral pain and temperature sensations. And you might have burning pain in the arms because of radiculopathy. You don't need to remember this one typically. You need to remember this, pain and temperature in the arms, sacral sparing, and bilateral motor paresis. These are three things you need to know. In terms of presentation, it's either a child, a baby, who has syringomyelia, or a type 1 carrier malformation, or you'll have an elderly patient who will have a whiplash type of injury, and then later on presents, okay, she can't feel anything, for example, or he can't feel anything in terms of pain sensations in the upper limb, okay, in the hands, but in the legs, it's normal. Okay, so that's central cord syndrome. The variable, the burning pain in the arms, I'm not sure why it's there. And I'm not sure why there's radiculopathy. I might be mistaken here. So double check on this. But as I said, remember the other signs, and that's all you need. You don't need to remember the burning pain in the arms. Okay. Is the central cord syndrome clear to you guys? So this one, it's that is very true. This basically fact, just remember that when it carries sensation, for example, from it's crossing over, okay, at the level of the cervical vertebra. So for example, it's carrying sensation from the upper arms. So for example, from C5 and C6, C7, okay? It will come to the spinal cord and then it will cross over. Since it's affecting the anterior commissural fibers at the level of the cervix, it will expand and only compress the fibers that's coming from these regions. The rest of the body has already been ascending upwards through the spinal thalamic tract. Does that make sense? Yeah, exactly. It depends on which level. Can you please repeat what age group central cord syndrome affects? So it's different depending on the etiology. So for example, you have syringomyelia, which is due to, for example, a type 1 carrier malformation. And it happens more in children, okay, in younger age groups. For example, in whiplash injury, it typically will affect more of the elderly age groups. So for example, you'll have a 40, 50-year-old patient who comes after a motor vehicle accident. 3 months later, they can't feel any, or they have progressive weakness or can't feel pain coming from the upper limb, or for example, they're cooking and they can't feel the temperature, okay? But from the lower limbs, it's all fine. Okay, so these are the different age groups I might present with. Okay, so why is it bilateral and why isn't it contralateral? Because it's growing from the center, okay? So for example, I'm gonna go to the earlier slides. So for example, if something's growing out from here, okay, so from the central canal, okay, it will expand all directions, okay? It won't expand only one way or it affects one side. So you'll have, for example, the spinal thalamic tract, it will come here, synapse on this side, and then it will cross this side. You'll have from this side as well, comes here, synapses, crosses over, and goes up. So it's affecting both sides, and I know this tract should be near to it. It will expand this way, and it will continue expanding and affects the anterior horn on both sides. Okay, that's why it's bilateral and not contralateral. Typically, no. Okay, you don't really, it does not typically in the cases or in the questions, it won't only grow in one direction, it will grow on both sides. It's just going to expand this way. So it typically does not grow in one direction. Does that answer it? Okay, perfect. Okay, so that's it for central cord syndrome, I believe. No, it's at the level of the lesion only. Okay, below, like For example, it'll affect multiple segments. For example, in the cervical segments, it will affect those. That's why it only affects the upper part of the body and not the lower part of the body. No problem. Okay, the next one is one of my favorite ones because I love explaining this, is the anterior cord syndrome. Now, I'm gonna explain it on this side because I need to explain the blood supply very quickly. So the blood supply, you'll have in the anterior part, you'll have the anterior spinal artery, and then you'll have posterior spinal arteries over here, okay? So basically, is that the anterior spinal artery will supply the anterior 2/3 of the spinal cord. The posterior spinal artery will only supply the posterior part, which is a posterior 1/3, which is a dorsal column tract. Which is exactly the how to neuro talk question, exactly. But basically, the dorsal column is going to be supplied, it's a posterior 1/3, and it's the only thing that's going to be supplied by the posterior circulation, which is going to be the posterior spinal artery. The anterior spinal artery will basically supply the anterior 2/3, which is everything except the dorsal column. Now, one concept is that you'll basically receive different arteries that will supply the spinal cord at the thoracic segment, specifically T8, because the blood supply here is a little weaker. So you'll have a communicating artery that will come and help supply the region. This artery is called, because I can't pronounce it ever, it's called the artery of Alfuwais, okay? So at the level of T8, for example, you'll have this artery of Alfuwais. Now, what happens is you have loss of blood supply. That's literally what the cause is, okay? So it doesn't matter why there's loss of blood supply, you'll have loss of blood supply. I'll explain what cases you might get in terms of this. But you'll have loss of blood supply coming from the anterior spinal artery or the artery of Alfuwais because of the T8, watershed region or the area that receives communication from other arteries to supply it. So with this, you'll have affecting all tracts, okay, except one, which is the dorsal column tract. So typically, what will happen is that at the level of where you have the ischemia, okay, at the anterior 2/3, at the level of the ischemia, you're going to have bilateral flaccid paralysis. Why is there bilateral flaccid paralysis? Is because of the anterior gray horn cells, which will be dying because of ischemia at the level of the lesion. Then you'll have at the level of the lesion, bilateral loss of pain and temperature sensations because of the spinothalamic tract coming from both sides, okay, will be gone. That's number one. And also you can see here, this, which is the anterior white chemistral fibers, it won't be able to cross over, so you'll have both sides as well. Then another thing, which is below the level of the lesion, you will have a spastic type of process bilateral. Why? Because the corticospinal tract won't be able to descend down because this area is going to be ischemic. So it will not descend down, but however, below the level of the lesion, everything will be normal. Okay, in terms of the lower motor neurons, it would be functional. So you'll have a spastic process below the level of the lesion bilaterally. Below the level of the lesion, bilaterally, you'll have loss of pain and temperature sensation, and you will have normal sensations of vibration and proprioception, okay? Because since the dorsal column will be spared. Okay, so that's basically the findings that you'll see. Now, when does it happen? Typically, you might have a patient who comes to you within basically a aortic aneurysm, okay, repair. So it comes and repair the aortic aneurysm, you're gonna need to clamp the aorta. And when you clamp the aorta, you'll have decreased blood supply going to the regions of the spinal cord that's depending on, for example, the artery of Alfuwais, which comes from the aorta, okay? So because of this, you might have the spinal cord will be ischemic, the anterior 2/3. Another thing is systemic hypoperfusion. You don't really need to remember this at all, but because you have heart failure, your heart is not pumping much blood anymore. It's not pumping good amount of blood that will go to the organs and perfuse it, including the spinal cord. So you'll have anterior cord syndrome as one of the things, and anything that's affecting the blood supply. So you'll have a patient with atherosclerosis or arterial sclerosis. You don't need to know what they are. Just remember that anything that leads to a decrease in blood perfusion to the spinal cord, okay? Typically the anterior cord, okay? So you'll have an anterior cord syndrome, just to recap, bilateral at the level of the lesion, bilateral flaccid paralysis, and bilateral loss of pain and temperature sensation. Below the level of the lesion, you'll have bilateral spastic paralysis and bilateral loss of pain and temperature sensation, okay? And there will be no loss of there will be no loss of what's it called, vibration and conscious proprioception. So at the level of lesion, let's just say you have ischemia to the level of T8, okay? So at the level of T8, you have this artery is occluded at T8, okay? So because of this, T8 will be ischemic. So at T8, or let's actually go up further, because I want to apply this with the brachial plexus, let's just say. So if you have, for example, level of C5, it will lead to a decrease in the reflexes coming from the biceps reflex, okay, for example, because of the C5, okay, I believe, if I'm not mistaken, could be wrong. But anyways, that's how you look at it. So for example, C6, C5, C7, C8, and then T1, you need to know what reflexes, how you test for each one. Or let's go, for example, L1 or S1, Achilles tendon, you check for Achilles tendon, and it will be flaccid, or it'll be hyporeflexia, okay, at the level of the Achilles tendon, which is going to be S1, S2. So because of this, you'll see, okay, he has flaccid process there. But below it, okay, so all the other sacral segments are going to be spastic. Okay, so that's how one way you can look at it. As you look at the reflexes coming from, for example, the triceps reflex or the biceps reflex, okay, or the knee patellar reflex, okay? Is it hypotonic or hyperreflexia or hyperreflexia? Below it, you'll see either it's a spastic process or flaccid, but it's most likely going to be spastic. So the calf muscles will be basically spastic and stuff like that, okay? Perfect. Okay, this lesion is pretty simple, but it's just an overview in terms of posterior cord syndrome. It's just an overview of a bunch of stuff. I'm going to explain all of them just one by one. I already explained syringomyelia and complete occlusion of the anterior spinal artery, done, okay? Now, the posterior cord, it will carry sensation of, I already mentioned, which is the vibration and conscious proprioception. So you have loss of proprioception, conscious proprioception, and vibration. That's typically what you'll find. How do you test for it again? Positive Romberg sign. The patient won't be able to tell where their finger is when you close their eyes. And then you'll have loss of vibration. You check tuning fork and you can't feel anything. Okay, so that's typically how they present with. Now for specific lesions. First thing is tabes dorsalis. So tabes dorsalis is basically an infection caused by the tertiary form of syphilis. Syphilis is an STD, okay? The primary form of syphilis will cause the signs of STD, okay? And then you'll have the secondary form of syphilis and the tertiary form. The tertiary form of syphilis will be the one that's affecting the spinal cord. Now, what will it affect? It will affect two things. It will affect this, which is the dorsal column tract, and it will affect the dorsal root ganglia, okay? So, or the dorsal roots, coming from the dorsal ganglia, obviously, but the dorsal roots. So now what will you present with? Let's just start with the dorsal column tract. You'll have loss of conscious proprioception and vibration, okay? Now, the next thing that you'll need to check is what can you test with the patient? You'll have a positive Romberg sign. And next thing is you'll have an absent deep tendon reflexes. Why? Why do you have an absent deep tendon reflex in tabes dorsalis? I want to see what you guys say. Exactly, because of the dorsal root. So again, sensations, because you want to elicit the deep tendon reflexes, it has to come to the spinal cord. How can it come to the spinal cord if you have deep tendon reflexes or it's gone? That's like the dorsal root that's gone. It can't. Okay, so that's why you have loss of or absence of deep tendon reflexes in this patient. Now you have something which is called Charcot joints. Charcot joints, it's basically going to lead to destruction of the joints. Typically it's a knee joint. So the patient you'll see is that they're going to be running into objects, running into a table, and not feeling pain in the knee. And this will lead to destruction and degeneration of the joint, of the knee joint over time. And it's a mimicker of osteoarthritis. You don't need to remember that. But basically it will cause obstruction of the joint, and they won't be feeling this because of loss of deep tendon reflexes and loss of sensation, since it's not coming back through the dorsal root anymore. Now, the next thing is Argyll-Robertson pupils. You won't need to know this specifically, but just to mention, is that the pupils will constrict due to two things. Either you shine light into their eyes, or you basically do the accommodation reflex, okay? So as you come closer, your pupils will constrict to accommodate for the object coming closer. So with Ariel Robertson pupils is that they will constrict due to accommodation, but they won't due to lights, okay? Due to light shining in their eyes. That's it. That's all you need to know for Ariel Robertson pupils. It's just a hint in case. But tabes dorsalis is, again, just to mention, is an infection for tertiary form of syphilis. You will have number 1, positive Romberg sign, okay? Loss of vibration, and you need to remember is that you will have Charcot joints, okay? And a loss of deep tendon reflexes, okay? Is tabes dorsalis clear? Cool. Now, the next one is vitamin B12 deficiency. Vitamin B12 deficiency. It's typical in terms of where can you see vitamin B12 deficiency is in patients who had gastrectomy, which is basically you take out part of the stomach. The reason is because the vitamin B12 to be absorbed, it needs intrinsic factor. And since you lose parietal cells from the stomach, you won't have intrinsic factor anymore, so you won't be able to absorb vitamin B12. That's one. If you have a distal ileal resection, you won't be able to absorb the vitamin B12 anymore. So these are just clues, okay? So you might have a patient who had a gastrectomy, think of vitamin B12, okay? That's how the patient will, past history of the patient is that they had an ileal resection or they had gastrectomy, okay? So that's number 1. Now, why does vitamin B12 cause this disease? Is because the myelin, for myelination, you need vitamin B12 as a factor, okay? So because of loss of vitamin B12 through a deficiency, you'll have demyelination or degeneration of specific tracts of the spinal cord. Now, which 3 tracts you need to remember is that it causes subacute combined degeneration, SCD. So you need to remember SCD tracts. S being the spinocerebellar tract, C being the corticospinal tract, and D being the dorsal column tracts. So if you have demyelination of the spinocerebellar tract, what will you find? Okay, good. Ataxia or unconscious proprioception loss, which is through ataxia. If you have the corticospinal tract that's demyelinated, what will you have? Spastic paralysis. Good. And if you have the dorsal column, what sign will you see? Sign. Romberg. Good. And loss of vibration and proprioception. Excellent. So that's basically what you'll find in patients with vitamin B12. Again, think of a past history patient who had gastrectomy or ileal resection, and then suddenly later on down the line, because it takes a bit of time, you'll have, a patient who has ataxia, you'll have a patient who has a spastic type of paralysis, and you'll have a patient with impaired proprioception and impaired, for example, vibration sensation. Okay. How similar is this to multiple sclerosis? Multiple sclerosis is completely different because this one is specific, okay? So vitamin B12 deficiency, it will affect these tracts specifically. In multiple sclerosis, you have a very, it really varies, okay? So the patient, firstly, in terms of presentation, will not have past history of gastrectomy or anything. That's number 1. Number 2 is that the patient's symptoms will come and go, okay? So it will basically, once you'll have a flare-up of symptoms, it will go away, but it will still be there, then it gets worse. Okay, that's number 2, the relapsing remitting phenomena in multiple sclerosis. And it varies, it completely varies, because you'll have demyelination of anything, okay? So it could be the corticospinal tract, it could be the spinothalamic tract, it could be the dorsal column tract, okay? Does that answer your question? Another thing to remember is in multiple sclerosis, I don't think you guys took the lecture yet. I think it's post-midterm. But basically, it's going to happen in a female patient, okay, mostly. And it's going to happen due to vitamin D deficiency. So you'll have a patient who lives up north in the North Pole, for example. That's just a way to see it, or in hot areas, okay? That's how you can tell multiple sclerosis. They won't feel anything. Like they won't feel much, because if the dorsal root ganglion or the dorsal root is affected, they won't feel sensations going into the spinal cord. That's why they have Charcot joints, because they can't feel, the pain coming from hitting a table. It won't, they won't feel it. So they'll keep hitting it, and this will lead to progressive degeneration of the knee. Okay, no problem. The last two things in the spinal cord, and then we will be done with the spinal cord. We'll have a short break, is the cauda equina syndrome and Friedreich's ataxia. Now, the cauda equina syndrome, at the level of L1, you'll have the conus medullaris, okay, which will be the end point of the spinal cord. Below it, you'll have all the spinal nerves coming from the spinal cord, which will be in a horsetail type of look. It's the cauda equina. Now, if you have a compression of the cauda equina, okay, due to any reason, for example, a vertebral disc herniation, or due to a tumor, at below the level of L2, you might have these signs, which is radicular pain, because you'll basically be impinging on a nerve, and impingement of a nerve would lead to radicular pain. Okay, that's just, you need to remember that impingement of nerve will lead to radicular pain, which is basically moving pain. Okay, so it won't be at one spot since it's a nerve, it will be moving. For example, if you think of sciatica, you'll have the pain that's radiating from the, the part of the back all the way down to the calf, for example. Okay, so that's what radicular pain is. You'll have absent knee and ankle reflexes, again, because of impingement of the nerves. Anything coming from, for example, the knee or the ankle will not, it will go back to the spinal cord, but since it's impinged, it won't be able to go back. So you'll have absent knee and ankle reflexes. Loss of bladder and anal sphincter control and sinus anesthesia. So because of, the sacral nerves that's going to be supplying the bladder and the anal sphincter, because it's a mixed nerve at this case, since it's left the spinal cord, it's gonna be a mixed nerve. So it'll carry autonomic functions, it will carry sensory functions, it'll carry motor functions, it'll carry everything. So it'll go and basically supply all the organs in the pelvis. So because of this, you might have loss of bladder and anal sphincter control, and you have a saddle type of anesthesia, which is basically in this picture in the behind section, you'll have loss of the areas, the inner parts of the buttocks. That's pretty much cauda equina syndrome. Okay, is that clear to you guys? Good, perfect. Okay, so the last thing is Friedreich's ataxia. Friedreich's ataxia is another congenital genetic defect. It's due to an autosomal recessive trinucleotide repeat disorder. So GAA is basically going to repeat multiple times. And it's on chromosome 9 that encodes frataxin, which is an iron-binding protein, leads to impairment in mitochondrial function. That's just basically the pathogenesis. What you need to know is how to recognize the disease, not typically the pathogenesis, but remember it's a trinucleotide repeat disorder. So you might get as one of the answer choices, trinucleotide repeat disorder of GAA. Okay, now how do you recognize this disease? Firstly, let's think of the spinal cord lesions. So you'll have lateral corticospinal tract, which will lead to what? Symptoms. Corticospinal tract. Okay, exactly. Pain, temperature loss is due to the spinothalamic, which is not injured in this case. Okay, so then the spinocerebellum, it will lead to ataxia. You'll have the dorsal column, which will lead to decreased vibration and proprioception. And then you have the dorsal root ganglia, which will lead to loss of deep tendon reflexes. Now, one thing you need to recognize is that's not the only thing that the patient will have. So the patient will come to you with, you do, for example, a X-ray, and the heart will be enlarged. Okay, that's number one. You'll have hypertrophic cardiomyopathy. And that's the cause of death to a patient. You might have a patient who's hyperglycemic. Okay, so they have diabetes mellitus. Okay, you might look at their toe and it's a hammer type of toe. It's like a shape of a hammer. That's another sign. And another sign is pes cavus, which is basically the high arch in the foot. And lastly, you'll have kyphoscoliosis. Scoliosis is going to be the sideways look. Kyphosis is, front and back, deviation of the vertebral column. Okay, so these are the things that you'll see in the patient. So you'll see a mix of, firstly, spinal cord lesions. Okay, so lateral corticospinal tract, spastic paralysis, ataxia, decreased vibration and proprioception, and a loss of deep tendon reflex. Plus, it'll tell you is that they have an enlarged heart and X-ray, and then they have hyperglycemia, they have diabetes and stuff like that. That's how you can tell Friedreich's ataxia. You need to use the other signs that the patient may have, okay? Does that make sense to everyone? Perfect. So now the last thing I will cover is spinal shock in this half of the series. So spinal shock it happens when you have an injury of the spinal cord. It will lead to an immediate loss of everything, from the spinal cord. So this is called areflexia. So below the level of the injury, you might have, bilateral flaccid paralysis. You might have, loss of all sensations and stuff like that below the level of the lesion. And this is not permanent, okay? This is usually temporary, okay? It will, subside with time, either, minutes or months later, and reflexes will gradually come back. How can you tell a patient if they're going through a spinal shock? They will have a slow heart rate with low blood pressure. And another thing is that you will have loss of somatic sensations and urinary bladder dysfunction. One way you can test for a patient with spinal shock is called the anal wink test. You basically pinch the tip of the penis, for example, and it will elicit a response that will cause contraction of the anal sphincter. If it doesn't contract, then you have loss of autonomic function, which is seen in spinal shock. After the spinal shock subsides, okay, so after all the reflexes come back, then you'll start seeing these syndromes, okay? You'll start to see these specific signs, all right? So that's what happens initially when you have a spinal cord injury. Okay, is that clear to you guys? Yes, typically, yeah. The dorsal root will be involved in Friedreich's ataxia. Is there any more questions before we go to questions on the spinal cord? Perfect. In central cord syndrome, what tracts will be affected exactly? Typically, it will affect the anterior white commissural fibers, which are basically the decussation or the crossing over of the spinothalamic. So you'll have bilateral loss of pain and temperature. And you'll have also affecting the anterior gray horn cells, which will lead to bilateral flaccid paralysis. So the tract that will be affected, it will be the the spinothalamic tract, which is the decussation part of it. Not the corticospinal tract. And no, you will not have spastic paralysis. No problem. Okay, so let's start with questions. I will read, and I want someone just to answer once I'm done. A 54-year-old man comes to the physician because of dysphagia and hoarseness of voice for the past 3 months. Initially, he had difficulty swallowing solid food, but now has difficulty swallowing porridge and liquid as well. He has recently been choking on his oral secretions. During this period, he had an 8-kilogram weight loss. He has noticed increasing weakness of both arms over the past year. He appears ill. His temperature is 36.8 degrees Celsius, pulse is 74, respiration is 14, and blood pressure is 114/74. Examination shows tongue atrophy and pooled oral secretions. There is diffuse muscle atrophy with occasional twitching. He is unable to lift his arms above the chest level. Deep tendon reflexes are 3+ in all extremities. Sensation to pinprick, light touch, and vibration is intact. Which of the following is most likely the cause of the patient's symptoms? Okay. So yes, the answer is A. Now we'll explain why it's A. Okay. So the first thing, elderly patient, more in the older age groups, has dysphagia and hoarseness of voice for the past 3 months. Okay. Initially, so the word initially tells you it's a progressing disease. So difficulty swallowing solid food, which is dysphagia, but then it turned into liquids. Then he's been choking on oral secretions. So we'll skip all of this because this doesn't matter. So then you have tongue atrophy, notes number 1, diffuse muscular atrophy with occasional twitching, and unable to lift his arms above the chest level. Deep tendon reflexes are 3+. All other sensations is intact. So this is ALS. Okay, amyotrophic lateral sclerosis. Why is this ALS? Firstly, you have to look that it's an upper motor neuron lesion and a lower motor neuron lesion with no sensory deficits. So sensory deficits, 0. Is it an upper motor neuron lesion? Yes. Why? Because you have deep tendon reflexes, which is hyperreflexia. Again, the normal is +2. Anything above it is hyperreflexia. Okay, so deep tendon reflexes are 3 positive or 3 plus, meaning it's hyperreflexia, upper motor neuron lesion. Is it a lower motor neuron lesion? Yes, it is, because you have diffuse muscular atrophy with occasional twitching. Okay, the occasional twitching is the muscle fasciculations I told you happens with a flaccid process. So you have atrophy because of the flaccid process or because of the denervation of the muscle. So you'll have lower motor neuron plus an upper motor neuron. What about the rest of this? Because it can affect the corticobulbar tract and also the cranial nerve nuclei. So this is affecting the vagus nerve, which is why they have dysphagia, hoarseness of voice, difficulty swallowing. Then it's also affecting the hypoglossal nerve, hence why the tongue atrophy. Is this clear to why this is ALS to you guys? Perfect. Dilation of the central spinal canal will lead to the central cord syndrome. It's not going to present like this at all. Okay, it will be loss of pain and temperature bilaterally and flaccid process bilaterally. You will have loss of sensations. Demyelination of peripheral nerves will not have this. Number one, you won't have an upper motor neuron lesion with this. You'll have mostly a flaccid process with peripheral nerves because it's a lower motor neuron. So that's, since you see this, you immediately can cross this out. Another thing is autoimmune destruction of acetylcholine receptors. This happens in, for example, myasthenia gravis. The presentation is completely different than myasthenia gravis. It's a progressing disease throughout the day. Okay, so you'll have the patient who has fatigue as they go through the day, and they have also involvement of the eye muscles, for example. And multiple cerebral infarctions will not lead to this. Again, as I mentioned in the beginning of the whole lecture, is that it will have a different distribution because of the homunculus. Okay, and this is all extremities. Okay, so that's this question done. Let's move on to the next one. So a 62-year-old woman with type 2 diabetes comes to the physician because of a 1-year history of progressively worsening paresthesias in her upper limbs. She has occasionally burned her fingers on hot dishes several times. She was involved in a motor vehicle collision 3 years ago. Neurologic examination shows absent temperature sensation with normal fine touch sensation over the upper extremities and upper chest. Further evaluation of this patient is most likely to show which of the following findings. This is something I actually did not fully mention in the topic, which thank God I put this question so I can explain what happens here. So at the level of, for example, the thoracic vertebra or thoracic columns, you'll have the lateral gray horn cells over here. So if it expands this way, it will also lead to Horner syndrome. Okay, so that's that. That's why they have some signs. So can someone answer this question? And I already showed the answer. Yeah. Okay. So exaggerated biceps reflex, that happens with an upper motor neuron lesion. Again, it's a lower motor neuron lesion. Okay, so it will not have this at all. And you'll have the absent anal wink reflex. That doesn't happen, okay, because it will happen with spinal shock. But this patient, it's been a 1-year history, not going to happen. And also you'll have, for example, flaccid process and everything, below the lesion and stuff like that. So it's not going to have absent anal wink reflex. Deviation of the jaw happens with a trigeminal nerve lesion. It does not affect the trigeminal nerve in the central cord because that's in the brainstem. And drooping of the eyelid, why? Because of Horner syndrome. Okay. Yes, this is central cord syndrome. Again, as I said, the history, look into the history. Okay. Firstly, cannot, burn her fingers on hot dishes, tells you something's wrong with temperature several times as well. Elderly patient, had a motor vehicle collision, whiplash injury. Okay. Does this make sense, everyone? Perfect. Last question. A 30-year-old man comes to the physician for a follow-up examination. He has quadriparesis as a result of a burst fracture of the cervical spine that occurred after a fall from his roof 1 month ago. He has urinary and bowel incontinence. He appears malnourished. His temperature is 37.1 degrees Celsius. His pulse is 38. Blood pressure is a bit hypotensive, okay, low. Examination shows spasticity in all extremities. Muscle strength is decreased in proximal and distal muscle groups bilaterally. Deep tendon reflexes are 4+ bilaterally. Plantar reflex shows extensor response, okay, bilaterally. Sensation to pinprick and temperature is absent below the neck. Sensation to vibration, position, and fine touch is normal bilaterally. Rectal tone is decreased. There's 1 centimeter area of erythema over the sacrum, which of the following is most likely the cause of this patient's symptoms. Good. It is D. Okay. This is anterior cord syndrome. All right. And you guys understand why this is anterior cord syndrome. Again, firstly, is that just look into this line, which is sensation, vibration, position, and fine touch is normal bilaterally. Everything else is damaged. Immediately go for anterior spinal artery. And another thing that you might need to look into is there's a fracture, might lead to disruption of blood supply because of, damaging of surrounding structures with a fracture of a vertebra. So that leads to decreased blood supply, but that's not as significant. What you need to look into is what are the other things. Spasticity in all extremities because it affects the cortical spinal tract on both sides. And then you'll have muscle strength is decreased. Again, same thing, the deep tendon reflexes are 4+, hyperreflexia, consistent with upper motor neuron lesion. Babinski sign positive, which is this thing right here. Plantar reflex shows extensor response bilaterally, Babinski sign. Sensation of pinprick and temperature is absent below the neck. Again, spinothalamic tracts. Okay, so this is a anterior spinal artery damage, anterior cord syndrome. And that concludes the spinal cord part of it. The rectal tone, I'm not completely sure why in this patient, but look into the other signs as well. And with the, all the lesions, look at the cumulative signs. I'm not sure why there's decreased rectal tone, honestly, in this patient. Probably because of sympathetic. Again, this was in the neck. So if you think about it, the oculosympathetic pathway will be damaged, or the sympathetic pathway is damaged, or even, any of the nerves. So because of this, it might affect it. Okay, we never really know. Does anyone have any questions of the spinal cord? Okay, so we'll take around let's just say it's 8:30. Do you guys want to continue, or do you want to break for 10 minutes? Okay, we have 1 continue. 1 break. 2 break. Okay. Okay, we'll take a 10-minute break, and then we'll be back around 8:40. Okay. All right. Welcome back, everyone. And now we're going to start with the brainstem, inshallah. So the brainstem is one of the more complicated parts of, neuro in terms of neuroanatomy. Inshallah, there are ways to simplify it. And I'll be going over ways how you can simplify the brainstem. Because the main thing about the brainstem, although the anatomy is very complex, but you need to know how to localize lesions. You need to know where you are at the brainstem. And that's what I'm going to do, inshallah, today. But if at any point you need to stop me, please let me know, okay? So the first thing as I'm going to review is the cranial nerves, and there's a lot of them. But I want to explain them in a more clinical context in terms of what would you see if this cranial nerve is damaged, okay? So now, let's start with the oculomotor nerve. The reason why I cut out the cranial nerve number 1 and 2 is because they have nothing to do with the brainstem. So you'll never see a lesion with the optic nerve or the olfactory nerve or anything because it's not going to be in the brainstem, okay? So we're going to start with the oculomotor. The oculomotor nerve, it's a motor nerve, but however, it will have some parasympathetic activity. But we'll start. So the first thing is the eye movement, which is the motor function of the oculomotor. Now, the oculomotor nerve will supply all the muscles of the eye except 2, which is the superior oblique and the lateral rectus. So it will typically move the eye, for example, medially, it will move it upwards, it will move it, for example, upwards to an angle, this way and that way, okay? So it will move it multiple different angles. what you need to remember is what happens if you have a lesion of the oculomotor nerve, okay? If you have a lesion of the oculomotor nerve, the eye will go down and out, okay? Down and out. That's how you'll see an oculomotor nerve damage. You will have other signs of oculomotor palsy. You'll have pupillary constriction, loss of pupillary constriction, so pupillary dilation, loss of the accommodation because it goes and supplies the ciliary muscle and the sphincter pupillae. However, also it will lead to a form of ptosis. I don't think you guys took it in neuro or will take it in neuro in terms of the different forms of ptosis, because in Horner syndrome, you have a specific type of ptosis, and in oculomotor nerve palsy, you'll have another type of ptosis. But basically, it's, it depends on which muscle. So in oculomotor, you have a complete ptosis. And you'll take this in more detail in head and neck, inshallah. So don't worry about this now. Remember that an oculomotor nerve palsy will lead to an eye going down and out. Okay? Down and out. That's what you need to remember specifically about the oculomotor nerve. Going next is the trochlear nerve. The trochlear nerve is also responsible for eye movements. It's one of the nerves that will supply one of the extraocular muscles, and this is going to be the superior oblique. Now, the superior oblique muscle will basically pull the eye downwards. Okay, so it'll pull it from the back. Okay, and it'll make the eye go downwards. Okay, so because of your eye going downwards now, you'll be able to, for example, read. Okay, so for example, if I have a book over here, or for example, I have my phone, I'll be able to read or look at my phone like this, okay? Or I'll be able to go downstairs. So one way to remember a trochlear nerve lesion is, how does it present with? It presents with a patient who has difficulty, for example, buttoning their shirt. They have a difficulty going downstairs. They have a difficulty reading what's below them like this, okay? So that's how a trochlear nerve palsy looks like. And you need to remember that specifically. These two nerves will be affected in midbrain lesions. Okay, and we'll get to how and where later on in this lecture. Now the trigeminal. The trigeminal is a mixed nerve, meaning that it has sensory, it has motor, okay? So the motor functions is that it will supply the muscles of mastication, which is all the muscles that are responsible for the chewing, okay? You don't need to know the muscle specifically. This is more in detail when you take head and neck, okay? But, which is very important, is the sensations that it carries. So the trigeminal nerve will carry sensations, facial sensations, of pain and temperature, okay? It will also carry proprioception. Now, the proprioception will come from this joint over here, which is the TMJ joint. And basically, it takes this sensation all the way back to the midbrain. There's a nucleus, which is the mesencephalic nucleus of the trigeminal. It will take it all the way back there. Not significant, okay? This function, which is the proprioceptive, not that important. What you need to remember is the sensations of pain and temperature coming from the face. It takes it through three different distributions. You have the ophthalmic, maxillary, and mandibular, okay? So the mandibular branch will have the muscles, the muscular function, which is for the mastication. So in a trigeminal nerve palsy, you'll have ipsilateral loss of pain and temperature sensations, okay? And another thing is that it carries general sensations from the tongue, okay? So this includes pain and temperature sensations from the tongue, specifically in the anterior 2/3 of the tongue. Remember the anterior 2/3 because another nerve will be the posterior 1/3. So anterior 2/3 of the tongue, it will be pain and temperature sensation. So if you have a trigeminal nerve lesion, okay, whether this is at the nucleus or the nerve, you will have, most importantly, ipsilateral loss of pain and temperature sensation from one side of the face, okay? The muscle mastication, it depends because it's different in terms of, the nerve. In terms of the brainstem, not as important, okay? So you don't really need to focus on this. You need to focus on the facial sensations, okay? The facial sensations are super important. You need to remember them very well for the trigeminal nerve. Another thing is the pain and temperature sensations from the anterior 2/3 of the tongue. That you also need to remember it. And there's another function, which is dampening of loud noises, not as significant as another nerve for the ear, okay? Abducens nerve is next. The abducens nerve is a motor nerve, okay? So it will only supply one extraocular muscle. Again, it's one of the muscles that moves the eyes. And this is the one muscle, which is the lateral rectus. It moves the eye laterally, okay? So if you have a defect in the abducens, you won't be able to move the eye laterally. That's it. Okay, it's as simple as that. The eye can't move laterally. So you have a patient who just goes medially. Okay, it can't go further than that because of the defect in the lateral rectus, because of the abducens nerve. Below that, this nerve right here, which is a very big and important nerve, the facial nerve. Now, the facial nerve will be a mixed nerve as well, because it has motor functions, it has some sensory functions, it takes taste sensations, it has parasympathetic functions, and I'll explain which ones. So the first thing is we need to remember the motor functions very well. Okay. Now the motor functions is going to supply all the muscles of the face. So all the facial muscles in terms of expression. So for example, smiling, for example, raising your eyebrows upwards, for example, frowning. All these movements of the face is by the facial nerve. However, the facial nerve will have different branches, and all these branches will supply different muscles. Okay. And I know in Yaqin's slides, in Dr. Yaqin's slides, he has a lot of slides that has like the root of the nerve. You don't really need to know them now, okay? Now you need to know what's in the brainstem and what comes out of the brainstem. What happens after that point, you'll take it more in detail in head and neck, okay? So you're not going to be tested on this specifically now. Okay, so the facial nerve will have 5 branches. That you need to know in terms of 5 branches that will supply the muscles responsible for facial movement. In terms of the ganglia, yes, like for example, where it goes and stuff like that, you don't really need to know it. For example, you don't need to know, okay, where does the chorda tympani come from? Where does it go to? Where does it go to in order to supply? Yes. However, the tract of the nerve, you don't need to know. Okay, you don't need to know the tract of the nerve after it leaves the brainstem. In this block, it's more of a topic for head and neck. Okay. So then you have the eye closing. The eye closing is the orbicularis oculi, one of the muscles that surrounds the eyes. It will, be responsible for eye closure. Now, important is there's this one specific muscle in the middle ear. This muscle is called the stapedius muscle. Now, in the middle ear, you will have very small bones, okay? And these bones are responsible for transmitting, for example, audio waves into mechanical, into fluid waves, okay? And this fluid wave will allow the hearing sensation. You don't need to know that, okay? Now, but what you need to know is that one of the bones, which is called the stapes bone, which is a very small bone, the smallest bone in the body, it's basically tuned by this muscle, which is the stapedius. So what happens is that the stapes, it will hit on a structure called the oval window. This oval window is basically between the mechanical forces and the fluid that's in the inner ear. So it will hit it and it will cause fluid to move on this side, which will cause the hearing sensations. If you have, for example, the stapes that will keep on hitting the oval window or hit it more, this will cause louder sounds. So what happens with the stapedius, it will basically tune it. Okay, it will modulate it. It won't allow it to, it will tense up, so it won't allow the stapes bone to hit it as much, hit the oval window as much. So the stapedius will tense up. It won't allow the stapes bone to hit the oval window, which will decrease the amount of hearing. Okay, it will modulate the auditory volume. So that's another function of the facial nerve, which is important. The next thing is the taste sensation. It takes taste sensation from the anterior 2/3 of the tongue. Okay, so that's also an important thing because of lesions. It has parasympathetic function. It's responsible for lacrimation, which is tears. It's responsible for salivation from 2 glands, which is the submandibular gland and the sublingual gland. So submandibular gland, which is over here, and the sublingual is right below the tongue. Okay, so these are the functions. Now, how do you have a patient who has a facial nerve palsy, which is Bell's palsy? It differs firstly, because if it's at the level of the brainstem, you'll have a specific way that will have the facial muscle atrophy. And if it happens above the level of the brainstem, specifically above the pons, it will show differently. I'll explain this in the next slide. But basically, if you have a facial nerve damage, you'll have paralysis of, for example, the face, okay, the facial muscles. So you'll have drooping of the eyelids or drooping of the eye, for example, or you have you can't really smile, you can't frown, you can't do anything. You'll have, for example, dribbling of saliva because you can't really control it. You'll have, for example, you won't be able to raise up your eyebrows, okay? So these are the typical signs of it, okay? So this side, for example, you ask the patient if it's on the right side to smile, this side will smile, this side can't, okay? That's one way. The one thing you need to remember is whether it's contralateral, ipsilateral, and whether the forehead is spared or not. And I'll explain this in the next slide, not now. The next thing is going to be the auditory modulation through stapedius. Again, it will control the stapes to decrease the amount of volume. So if you have a lesion of the facial nerve, the stapedius muscle won't be able to function. So the stapes will be more, it will hit over the window more. So you'll have hyperacusis, meaning that you'll hear louder volumes, okay? The next thing is taste sensation. It takes taste sensation from the anterior 2/3 of the tongue through the chorda tympani branch. So if you have a lesion of the facial nerve, you won't be able to taste anything from the anterior 2/3 of the tongue. The posterior 1/3 will be spared because it's another nerve that supplies it. Now, distinguishing point, if it's loss of pain and temperature sensation from the anterior 2/3 of the tongue, which nerve is damaged? Pain and temperature. Trigeminal, excellent. If it's loss of taste sensation from that anterior 2/3, facial, good. Okay, perfect. Now, you might have loss of, tearing, you might have dry mouth coming with facial nerve palsy because of the salivation from the submandibular and sublingual glands, okay? So that's facial nerve palsy. Again, there's one more important concept of the facial nerve. I'll explain in the next slide, inshallah. Now for the vestibular cochlear nerve, it's the 8th cranial nerve. It's responsible for hearing and for balance, okay? So the vestibular part of it, it's not too important in the brainstem because it's multiple nuclei that's everywhere, okay? It's between the medulla and the pons. So it's not as important in terms of localizing where you are in the brainstem. But vestibular problems will come from the balance. We'll have, for example, nystagmus, which is basically the eye going like this. You'll have ataxia. You'll have, ataxia, and you'll have vertigo. Vertigo is basically the sensation of the world spinning around you, okay? That's pretty much that. The vestibule will function with the cerebellum, and you'll take this inshallah when you take the cerebellum, or you probably have already taken it, but it's not in the midterm inshallah. Now, the more important thing is the hearing function. Now, hearing, it needs to happen bilaterally to have significant hearing loss, okay? What happens with a brainstem lesion is you might have tinnitus, okay? Which is ringing of the ear, okay? That's the lesion that you have with the vestibular cochlear nerve. Okay, tinnitus, which is ringing of the ear. To cause significant hearing loss, you need to have bilateral damage. Just remember that concept. Next thing is glossopharyngeal nerve. The glossopharyngeal nerve, it's a mixed nerve. It will have motor, but the motor is not as significant. It's only one motor function, which is the stylopharyngeus muscle. The stylopharyngeus is responsible for elevation of the pharynx and larynx. But it takes taste and sensations, where from the posterior 1/3 of the tongue. Okay, and it's very important for the swallowing and the salivation reflexes. Okay, so sorry, for the swallowing and for salivation, because salivation to the parotid gland, but it's not as significant clinically, this function. What you might have with a glossopharyngeal nerve palsy is you have an absence of gag reflex, because the afferent arm, which basically means it carries sensations of pain and temperature, or of anything in terms of sensations from the pharynx, is through the glossopharyngeal. Then it will go back to the brainstem, and through the nucleus ambiguous, it will basically act on the pharyngeal muscles and the laryngeal muscles. Okay, so the afferent arm is through the glossopharyngeal nerve. If you have damage to this, you have loss of the gag reflex. And another thing is you might have difficulty swallowing, dysphagia. You might have dry mouth because of the parotid, but it's not as significant. You might not have it actually. Then you might have loss of sensation, loss of taste and general sensations from the posterior 1/3 of the tongue. So that's the typical feature of a glossopharyngeal palsy. Taste and general sensation loss from the posterior 1/3 of the tongue. You might have dysphagia, but it's not as prominent as the next nerve, which is the vagus nerve. And you might have, for example, loss of the gag reflex, okay? The posterior 1/3 of the tongue is the most important finding that you need to look into. Next is the vagus nerve. It's a mixed nerve. It supplies all the muscles of the pharynx and larynx, all except one, which is the stylopharyngeus. So if you remember from first year, you have the recurrent laryngeal nerve, okay, which is a branch of the vagus nerve. It supplies everything. So if you have a damage of the recurrent laryngeal nerve, what was the finding that you might see? What happens to the voice? Hoarseness of voice. Okay, good. Same thing can be found here. If it's one-sided, yeah, exactly. So the same thing could be found here because you have hoarseness of voice. Okay, so that's one finding that you might have. The most important one is dysphagia. Okay, difficulty swallowing. Since the whole thing is, you need to have, the swallowing, which is all the functions of the pharynx and laryngeal muscles. If you have loss of them, you want to be able to swallow properly. So you have difficulty swallowing, which is dysphagia. Important thing, which is the uvula. The uvula you need to look into because it deviates when you have lesions. The uvula, however, unlike the next thing, which is the hypoglossal, which will be on one side, but the uvula will deviate away from the side of the lesion. So if you have the right vagus nerve that's injured, the uvula will deviate left. Why is that the case? Is because the right muscles won't be able to pull the uvula anymore. However, the left side of the muscles will. So it will pull the uvula towards the left side. Okay, so the uvula will deviate away, so contralateral to the side of the lesion. Remember that sign very well, because that's typically how they'll tell you is that the uvula is deviating towards the left or the right. So if they tell you it's deviating towards the left, you know that the lesion's on the right side. Okay. You might have difficulty talking against, again, laryngeal and pharyngeal muscles damage. And you have also another function of the vagus nerve, which is parasympathetic. It's parasympathetic to all the thoraco-abdominal organs until the transverse colon and the 2/3 of the transverse colon, I believe. Okay, so that's the vagus nerve. The other thing is going to be the accessory nerve. The accessory nerve will come from the medulla, and it's a spinal part of the accessory nerve. Now, the accessory nerve, it is motor to two muscles, which is the trapezius muscle and the sternocleidomastoid muscle. The trapezius muscle will be responsible for shrugging of the shoulder, okay? The sternocleidomastoid, it's basically for the turning of the head towards the other side. So, for example, this sternocleidomastoid on my right side will allow me to turn my head towards the left, okay? And then my left one will turn my head towards the right, okay? So this is the function of the sternocleidomastoid. So if you have a lesion of the accessory nerve, you won't be able to shrug your shoulders properly. So you tell the patient, okay, can you shrug your shoulder? If you have a defect in the right accessory nerve, you won't be able to shrug your shoulder on the right side. Left side is fine, okay? Now, if you have the right accessory nerve, will you be able to turn your head right or left? Will you be able to? Which side can you turn your head? Good, right side. Excellent, perfect. That's it. Okay, so accessory nerve, you can't turn your head towards the other side. Okay, so if it's on the right, you can't turn your head towards the left. Okay, that's it. The last nerve, which is a purely motor nerve, it's hypoglossal nerve, and it supplies the tongue, okay, the muscles of the tongue. So if you have a damage to the hypoglossal, you have tongue atrophy. Now, typically, if it affects a side, so for example, if it's a right hypoglossal nerve, the tongue will deviate towards the side of the lesion, not away, okay? That's pretty much it. You look that the tongue will be atrophied, there will be fasciculations because of atrophy, and it will deviate towards the side of the lesion. The one that does not deviate towards the side of the lesion, deviates away, is the uvula, okay? And this is a sign of a vagus nerve pulse. Yeah, pretty much. Okay. Are the cranial nerves clear to you guys? Do you have any questions? And the pulses for the cranial nerve? Because there's only one more concept I need to cover for cranial nerves, which is the facial nerve. But do you guys have any other questions? I guess all is clear. Inshallah. Okay. Is the trochlear concha? No, ipsilateral. So, for example, if you have a right midbrain infarction affecting the trochlear nerve, it's this one, the right side. No problem. Okay, so now we'll go into the one more question, I think. Okay, perfect. Okay, so the facial nerve. Now, the facial nerve nucleus, it's divided into two. It's divided into an upper half or upper 1/3 and lower 1/3. What you need to remember is that if you have a lesion of the nucleus of the facial nerve or the facial nerve itself, okay, this would lead to ipsilateral loss, okay, or ipsilateral flaccid process of the face, okay, of the entire face, okay, if this is at the nucleus or the facial nerve itself. If it's the cortical bulbar tract that's affecting the nerve that's damaged, the nucleus is bilaterally supplied in the upper 1/3. What does this mean? If it's both cortical bulbar tract coming from both primary motor cortices are damaged, then you'll have the upper 1/3 damaged. Okay, you will have paralysis of the forehead, for example. If it's only one side, it will be spared. Okay, the reason why is because the upper 1/3 is bilaterally supplied. The lower 2/3 isn't. Okay, it's only unilateral. So you need to, so if it's just cortical bulbar tract that's damaged, one of them on the right side, you'll have the left side that's damaged. Okay, the contralateral lower half of the face, lower 2/3 of the face. So in the contralateral lower 2/3 of the face, the forehead is spared. Okay, so that's how you're going to have it in a clinical case, is that the lower 2/3 of the face is fine. Okay, is that clear? So just remember, if it's anything cortical bulbar tract, just remember that it will be the contralateral lower 2/3 of the face. Okay, cortical bulbar tract. So meaning anything coming from the midbrain, let's just say. Okay, or above it. Okay, if it's affecting the pons, okay, or where the facial nerve nucleus is, or the facial nerve itself, it's going to be ipsilateral full face. Okay, that's it. Now let's go into the external features of the brainstem, just so I can tell you where the nerves are. Okay, the anatomy of it. Mariam Al-Tayyib should have given you a palpation. She did, regarding the general anatomy of the brainstem. Go over that and go over the lecture for this. But I'm just going to show you where all the nerves are, just so you're oriented to where the lesions might be. So the first thing is externally in the anterior part. You will have, firstly, let's start from the midbrain. You'll have the cerebral peduncles, which are these structures over here, and then this nerve that's coming out from the anterior part of it through the intracerebral fossa. I think that's called fossa. Anyways, you'll have this nerve right here, which is the oculomotor nerve, okay, coming from the anterior part. The only nerve that's coming from the posterior part of the brainstem, which is below the level of the inferior colliculus, is this, okay? This thing right here is the trochlear nerve. It comes posteriorly and goes in front. Then you'll have the pons. Okay, this nerve over here, by the way, is the optic nerve. You do not need to know the optic nerve in terms of the brainstem at all. It's not covered in the brainstem. It has nothing to do with the brainstem. You need to know these two. So coming from the midbrain are two cranial nerves, oculomotor and trochlear nerves. Okay, now pons. Pons, the significance of the external anatomy is this thing right here, which is the basilar groove or the pontine groove where you have the basilar artery. Okay, then you have this. This nerve over here is a trigeminal nerve. It will have a motor, which is the small one over here, and it will have the sensory, which is this big one over here. And it'll go supply all the sensation, or to carry all the sensations from the face, the proprioception from the face as well, from the TMJ, and it will also supply all the muscles of mastication. Then you'll have the lower parts of the pons, which is in the pontomedullary junction. You'll have three nerves. This one right here is the abducens nerve. It's the most medial one. Then you'll have this one right here, which is going to be the facial nerve. Then the most lateral one, which is going to be the vestibulocochlear nerve. Okay. Then going through the medulla. Medulla, first thing, the distinguishing point of the medulla, which is going to be these pyramids right here. And then this thing right here, which is the X-shaped structure right there. This is the pyramidal decussation of the corticospinal tracts. This right here, which is between the pyramids and this structure right here, which is the olives, okay? This thing right here is a hypoglossal nerve. Then you'll have the accessory, the vagus, and then this one right here, which is, the glossopharyngeal, vagus, and then the accessory nerve, okay? So this is what you need to know from the external. So to recap, which cranial nerves are at which level of the brainstem? At the level of the midbrain, you'll have two, okay? The oculomotor nerve and the trochlear nerve. Level of the pons, you'll have four. You'll have the trigeminal, abducens, facial, and vestibulocochlear. Level of the medulla, you'll have four. Hypoglossal, glossopharyngeal, vagus, and the accessory nerve. Is this clear to you guys? If no, let me know what exactly. Okay. Now, I'm going to very quickly just go over where the nuclei is, but you already know basics of it. So I can go over this very fast. So firstly, midbrain, you'll have a couple of nuclei. You have the oculomotor nucleus, which is more significant. You need to remember the oculomotor nucleus. And you need to know the trochlear nucleus in the midbrain. Then this thing right here, which is not clinically significant or important, you don't need to know it for lesions. You need to know where it is and what it does, which is the mesencephalic nucleus, which is for the proprioception coming from the TMJ. Okay, that's pretty much it. Then you go to the medulla, the pons. Then in the pons, you have multiple ones. In the most medial one, it's the abducens nerve, okay, abducens nucleus. Then you'll have, for example, the motor nucleus of the trigeminal, and you have this one right here, which is the most important nucleus for the trigeminal. It's the nucleus, it's the spinal nucleus of the trigeminal nerve, or the spinal trigeminal nucleus. Okay, this one is the one that's responsible for carrying pain and temperature sensations from the ipsilateral side of the face. Okay, very important one, and it's very huge. Okay, it spans the medulla and the pons. So this tract, if you just think about it, since it's huge and it spans the pons and the medulla, you don't really need to use it to localize whether you're in the pons or the medulla. Okay, you need it for another thing, which we'll get to later. Then you'll have the facial motor nucleus. Okay, it's a little bit more lateral. Okay, then you'll have the salivatory nucleus, superior, inferior, superior for facial, inferior for glossopharyngeal. Then you'll go to the medulla. Okay, now you can see here that the vestibular nucleus is going to be crossing between the pons and the medulla. That's why it's not as important for the vestibular signs. You need to know the cochlear sign, which is mostly in the pons. Okay, and now here, the most midline nucleus in the medulla is going to be the hypoglossal. And remember, you need to remember that the most midline nucleus in the medulla is the hypoglossal nucleus. Then you'll have the dorsal nucleus of the vagus nerve. Then you have the nucleus ambiguous. The nucleus ambiguous is important because nucleus ambiguous is the one that's responsible for the motor functions of vagus and the glossopharyngeal nerves. So because of this, you'll have dysphagia if you have a lesion in the nucleus ambiguous. Then this whole nucleus right here, which is the nucleus tractus solitarius, it's responsible for the taste sensations. Okay, so that's pretty much that. Okay, in terms of the nuclei. If you have more, if you want to go into more detail with it, which I highly recommend you do so in terms of just studying and reviewing the nuclei, the different sensations and stuff like that, go into the brainstem, just general anatomy of the brainstem. Okay, for localizing lesions, you need to know where the nuclei is. And there's an easy way to do so. And you need to know the general functions of them, okay? So that's that. Now we'll go into a bit more detail into the lesions and more clinical side of it, which is the whole point of this. So now the blood supply. The blood supply, I'll explain firstly the circle of Willis, just the posterior circulation, because that's an important thing with the brainstem, and not the anterior circulation, because that's more in the cerebrum. Nucleus ambiguous contribute to cranial nerve 12? No, it does not. The cranial nerve 12 is a hypoglossal nerve, and you need to know that the hypoglossal is just its own nucleus. Okay, no problem. Okay, so the blood supply, you'll have these two arteries, which are the vertebral arteries, and you'll have the anterior spinal artery. Now, the anterior spinal artery will be the major supply of the medulla, okay? So the medulla, if you look into the medulla over here, is that the anterior spinal artery will come up here, okay? Then it will join with the vertebral arteries. Once it joins with the vertebral arteries, the two vertebral arteries will join together and form the basilar artery, okay? Before that, the vertebral arteries will give off a artery that will supply the inferior part of the cerebellum, and to supply the lateral parts of the medulla. This is called the posterior inferior cerebellar artery. Okay? Then you move up to, as soon as the two vertebral arteries join together and to form the basilar artery, you have this artery right here, which is the anterior inferior cerebellar artery, which will supply the middle part of the cerebellum. Okay, so the middle cerebellar peduncles, and it will also supply the lateral parts of the pons. Okay? Then you go up the basilar artery. The basilar artery will supply the median part of the pons. Okay. Then you'll have the superior cerebellar, okay, which will supply the cerebellum. And then you'll have the posterior cerebral artery, which will supply the midbrain. Okay. So to remember it, this is an easy diagram for boards and beyond. That just shows it to you. Medulla, medially will be the anterior spinal artery. Laterally will be the posterior inferior cerebellar artery. Medially for the pons will be the basilar artery. Laterally will be the anterior inferior cerebellar artery. Then the midbrain will be the posterior cerebral artery. Okay, so this is the general blood supply of the brainstem. You need to know the blood supply because usually how they might test you is they give you signs and symptoms of a part of the brainstem that's damaged. They might ask you, what's the blood supply of this region? Okay, that's just a question that they might ask you. So you need to know the blood supply in this regard. So for example, if they give you a lateral pontine lesion, you might need to know, okay, lateral pons is supplied by the anterior inferior cerebellar artery. Okay, so stuff like this. So you need to master this. Okay, so that's that. Any questions regarding this? Okay. Now we get into the cool stuff, which is now we start to actually learn about these lesions and how to apply all the basic anatomy now that we've learned about the brainstem. So now, to recap, you have nuclei that are present in the brainstem, and then you have tracts. How do you have tracts? Is everything from the spinal cord that we talked about in the last hour and a half is going up to the brainstem. Okay, so it has to go up to the brainstem and then goes all the way up to the brain. Okay, or you have tracts coming down. So if you look into here, the motor tracts will run anteriorly, okay, and medially. Okay, the motor sensations, the proprioception, and the vibration sensations from the body is going to go in the midline through the medial meniscus. Then you'll have the sensations of pain and temperature, which is through the spinothalamic. It crosses over and it stays laterally. Okay, so now we apply it in the rule of all this information that we've learned. So first of all, the cranial nerve nuclei. The cranial nerves, you have 4 cranial nerves above the pons, 4 cranial nerves in the pons, and 4 cranial nerves in the medulla. What are the 4 above the pons? Because I mentioned this already, so I want you guys to say it. 1, 2, 3, 4. Excellent. The ones that are relevant to the brainstem are 3 and 4. So ignore 1 and 2 for now. What are the 4 in the pons? 4, 5, 6, 7. Good. Yeah, and 8. 4 is no. It's 5, 6, 7, 8. And then what are the 4 in the medulla? 9, 10, 11, 12. Good. So now, since you have these 12, let's just divide, for example, 12 by 4, you get 3. 12 by 3, you get 4. 12 by 6, you get 2. And 12 by 12, you get 1. So anything that's equally divisible by 12 is in the midline. Okay? Just remember that. Equally divisible by 12 is in the midline. So this involves 3, 4, 6, and 12. All these nuclei are for cranial nerves that are motor. Okay, so remember the motor is in the midline. Okay, motor nuclei are in the midline with a few exceptions. Just for example, the facial nerve. For example, the trigeminal, part of the motor functional mastication. Remember that they aren't pure motor at all. The pure motor ones are usually down the center, except oculomotor with some of the other functions that it has. But just remember that the pure motor ones are in the midline. Okay. So that's that. The other ones are laterally. And these are the ones that are on the side that are not divisible by 12. For example, cranial nerves 5, trigeminal, 7, okay, accessory, and the vagus nerve. Okay, they're not divisible by 12. So you think of it as lateral. Okay. That's how you apply the cranial nerve nuclei. Okay, so again, the pure motor ones, which are 3, 4, 6, and 12, are in the midline. Then you apply, okay, where is cranial nerve 3 and 4? They're in the pons. Where is the cranial nerve number 6? It's in, 3 and 4 in the midbrain. 6 is in the pons, 12 is in the medulla. Okay, so once you see a guy who has the tongue deviated to one side, you think of hypoglossal, which is the motor nuclei. So it's down the midline and it's in the medulla. Okay, that's how you localize it, just like that. If you have a patient who can't look laterally, okay, the eye can't look laterally, this is abducens nerve. So, okay, so abducens is going to be a motor nerve. So it's down the midline and it's in the pons, so medial pons. Okay. Patient can't, his eyes are looking down and out. You think midbrain, medially. Okay. Yeah, sure. I'll ask more questions. That's fine. Okay. So that's pretty much that. And now I'll go to the tracks, okay, or what happens in the midline. So in the midline, you'll have the motor nuclei. Which motor nuclei again are in the midline? Three, 4, 6, and 12. Excellent. Good. So then you have the motor pathway. The motor pathway is through the cortical spinal tracts. Okay, the same cortical spinal tracts that we had in spinal cord. They're descending down through the anterior parts of, for example, the pons, through the medulla, and it will decussate at the lower part of the medulla and descend down. Okay, so if you have a lesion of the right side of the anterior basilar part of the pons, where the cortical spinal tracts is, where would you have spastic paralysis? Left or right? Left. Contralateral. Excellent. Good. Because it crosses over at the medulla, lower medulla. Okay, since I said pons, and that's that. Then you have, so that's the motor pathways. However, above the medulla, at the level of the pons, you have cortical bulbar tracts, which are basically the ones that are the cortical spinal tracts for the cranial nerve nuclei. Okay, so that's that. Then you have the medial longitudinal fasciculus, which is in the midline. What is the medial longitudinal fasciculus? It's basically a communication between different cranial nerve nuclei. Okay, typically the cranial nerves that are moving the eye. It's a communication point for those nuclei. Specifically, cranial nerves 3 and 6. Okay. So, for example, and this is more going to be a concept that you're going to study more in depth in head and neck, not now, but just to explain it, is if you have a lesion in the medial longitudinal fasciculus, it will lead to internuclear ophthalmoplegia. This is basically this. So if you're trying to move your eyes laterally, so my eye, for example, my left eye is looking laterally and my right eye is looking medially. If my right eye is looking medial, which nerve is doing the medial rotation? Three. Which on my left, okay, excellent, it's oculomotor. On my left eye, which nerve is responsible for turning it laterally? 6. So if you have lesion in the MLF, in the medial longitudinal fasciculus, this will not be coordinated at all. Okay, so you have one eye that will turn lateral, one eye that will stay medial. Or, for example, you'll turn your eye medial, this one will not be able to turn lateral. Okay, something like that. The concept is a bit confusing, but there's a video I might send you guys or link it in this video, in this PowerPoint later on, that you might watch it for the MLF. Okay, so that's pretty much the MLF lesion. And now the medial lemniscus. The medial lemniscus comes from which tract from the spinal cord? Dorsal column tract. Excellent. So it carries which sensations? Vibration and conscious proprioception. Okay, good. Fine touch as well. Good. So it crosses over at the level of the lower medulla, as we mentioned before. So then it will cross over and ascend as a medial lemniscus. It will ascend in the midline. Okay, so everything in the midline on the side of it will be the medial lemniscus. Remember that. So just to make it simple, anything that starts with them, motor nuclei, motor pathway, MLF, and medial lemniscus will be in the midline. Okay. Just a simple thing. Now we go to the side ones, which is the lateral things. So laterally, you'll have the sympathetic, which is important because you might have Horner syndrome, ipsilaterally. Okay. You might have a spinothalamic. Now, spinothalamic carries sensations of what again? The pain and temperature. Good. And it comes from the contralateral side of the body, obviously. Then you have sensory. Now, this is sensory from the face. Okay, this is sensory of pain and temperature coming from the ipsilateral side of the face through the trigeminal. Which nucleus of the trigeminal? The spinal trigeminal nucleus. Okay, the spinal trigeminal nucleus. Okay, so that's that. So you have a lesion in the lateral part of the medulla. Okay, what would you expect? Let's just say on the right side of the medulla. Okay, right lateral medulla. Would you have the sensory loss of pain and temperature from the face on the right side or left side? Same side, on the right side. How about from the body? Contra, excellent. Left side, good. Now for spinocerebellar, it will lead to ataxia. okay? It will lead to ataxia. It will lead to, for example, if it's the vestibular nucleus also involved, you might have vertigo, okay? You might have signs of imbalance and poor coordination with the spinocerebellar. Just remember that anything affecting, for example, the sensory functions of pain and temperature, once you see pain and temperature loss, think lateral sides, okay? Once you see, for example, anything affecting the motor functions, think medially, okay? That's pretty much how you've localized brainstem lesions. So now that you got this, I'll go over it one by one in terms of the different lesions, where the cranial nerve nuclei are, what are the signs and symptoms, and how can you localize it. But using this rule, just you can localize where it is. So by knowing the level of where you have the third, fourth, sixth, and 12th, you can find where you are in the brainstem in terms of it's the midbrain, pons, or medial, okay? Then you look, okay, is it medial or lateral? If it's medial, you might have contralateral spastic paralysis. You might have contralateral loss of proprioception and of vibration, okay? You might have intranuclear ophthalmoplegia, okay? And you'll have, obviously, cranial nerve, 3, 4, 6, and 12. If it's 3, eyes down and out. If it's a 6, if it's 4, for example, the eyes won't be able to look down. If it's 6, the eyes won't be able to look laterally. And if it's 12, the tongue will be atrophied and it will turn to the side of the lesion, okay? Then now, if you don't have any of these, if you have, for example, a patient who has dysphagia, okay, which is vagus nerve, it's more laterally. Now, you know it's laterally and you know it's in the medulla. So now you have that. Then you have, okay, ipsilateral loss of pain and temperature from the face and contralateral loss of pain and temperature from this other side of the body, okay? Is this clear to everyone before I move on? Okay. Yes. What is your question? Okay, that's more in the midbrain, but in the midbrain lesions, it's not as important in terms of the dorsal column, because in the midbrain, you have 2 types of lesions. I'll get to it. You'll see other signs, okay? And with the midbrain also, you'll need to know the position of something which are called the red nucleus, okay? And the positions of the corticospinal tracts, okay? Once you know both of these, you know where you are in the midbrain. You know which lesion it is in the midbrain, okay? So that's what you really need to know in the midbrain. For the dorsal column, yes, there is a change where it becomes like in a row, okay, like this. I'm not too sure of the row, but again, go back to the anatomy part of it and the specific anatomy and apply it there. However, for the lesions that you studied, it's not as important knowing where that tract is, okay? No problem. So now going over the cranial nerves again, above the pons, it's oculomotor and trochlear. Oculomotor, the eye is turned out, down and out, and the trochlear, you won't be able to look down, okay? So you will have difficulty going downstairs, for example. Moving on. The trigeminal, ipsilateral facial sensory loss, abducens, the ipsilateral eye abduction, which is lateral rotation, is weakened. Facial nerve, ipsilateral facial weakness or droop. Again, if it's the facial nucleus, it's ipsilateral. If it's above the pons, where it's a corticobulbar tracts that are damaged, it's not going to be ipsilateral anymore. It's going to be contralateral, lower 2/3 of the face, sparing the forehead, okay? Auditory, again, that's why there's no vestibular part, because it's insignificant, because it's multiple parts and you need to damage a lot of it. You'll have ipsilateral deafness, but again, for the auditory part, for it to actually significantly cause auditory damage, usually is both sides. So the typical presentation of a vestibulocochlear nerve in the brainstem is tinnitus, okay, ringing of the ear, okay? Now, the glossopharyngeal nerve, ipsilateral pharyngeal sensory loss. You might have loss of gag reflex, as I mentioned earlier on. You might have loss of taste and sensation, general sensation of the posterior 1/3 of the tongue. Vagus nerve, ipsilateral palatal weakness, dysphagia, okay, hoarseness of voice, difficulty speaking, and stuff like that, and difficulty cough reflex, okay? Then the spinal accessory, which is going to be ipsilateral shoulder weakness, and then you can't turn your head towards the other side. Okay, then the hypoglossal nerve, which is going to be for the tongue. Okay, so movement of the tongue, either movement of the tongue. So if you have a weakness of the hypoglossal nerve on the right side, you'll have the tongue deviating toward the right. Okay. Now the midline structures, corticospinal tract, which will lead to contralateral weakness, which is going to be a spastic type of process. Medial meniscus, which is contralateral loss of proprioception and vibration. MLF, which will lead to ipsilateral internuclear ophthalmoplegia. Motor nucleus nerve, which will lead to each of these. 3, which will be the eye down and out ipsilaterally. 4, the eye can't look down ipsilaterally. 6, the eye can't look laterally ipsilateral. And 12, the tongue will deviate towards the side of the lesion ipsilateral. Okay. From the side, you have spinocerebellar, ataxia, spinothalamic, contralateral loss of pain and temperature, sensory nucleus of the cranial nerve 5, or the sensory nucleus of cranial nerve number 5, which is ipsilateral pain and temperature loss in face, and the sympathetic, which will lead to ipsilateral Horner syndrome. Now that we covered that, let's start to apply it, and this will be much quicker. Okay, inshallah, that we know the basics. So now I'm gonna be testing you guys with this, because now we just apply it to the knowledge, okay, that we've learned. So this is just a general overview of the medulla, a cross section. Let's just say I'm gonna take this part over here and this part over here, okay, and I'm gonna cut. This is gonna be the right side, this is gonna be the left side. I'm gonna do some cutting, which is all the way around here. Okay, so the first thing is, what cranial nerve damage will you see with this patient? If it's at the medulla, 12. So if it's on the left side, where would the tongue deviate to? Towards the left. Good. So that's the first thing that you'll see with this syndrome. Okay, that's number 1. Do you have loss of pain and temperature, or do you have loss of proprioception and vibration? Vibration and proprioception. Which tract is damaged? The medial meniscus. Do not call it dorsal column, because dorsal is in the spinal cord. It's the medial meniscus in this case. Okay, so that's that. Is it going to be right side or left side? Contralateral. So this is going to be on the right side. Good. Now, will you have spastic paralysis with this patient? Yes. Okay. Where? Right or left side? Contralateral. So it's going to be on the right side. Okay. So you'll have spastic type of paralysis on the right side. Okay. Perfect. This spastic paralysis muscles. It's corticospinal tract, because again, the corticospinal tract will be in the midline. That's number 1. And second of all, it's going to be right here. Yeah, exactly. So in the midline, so in the medial medullary syndrome, okay, that's the first syndrome of the medulla, is you'll have the tongue moving to the ipsilateral side. So if it's on the left side, it will move laterally, to the left side. Okay. Second of all, you'll have right-sided loss of vibration and proprioception. You'll have right-sided, right-sided spastic paralysis. Okay, and you'll have left-sided INO, which is internuclear ophthalmoplegia, because of the MLF. Okay, is this syndrome clear? Medial medullary syndrome. Good. Okay, now the specifics in terms of how it happens, I'll get to it in no slides for it, but just knowing how to localize it is very important. Okay, because the way they'll tell you that the hypoglossal nerve is damaged, or the tongue is deviating towards the left. What other signs can you see? Which is going to be right-sided spastic paralysis or right-sided loss of vibration, proprioception. Okay, so know where you are in the brainstem. Hypoglossal, think medially, and then the medulla. Done. Now let's just take this thing right here. Okay, that. So I'm going to actually clear to make it less confusing. Okay, and then I'm going to go back. Whoops. Okay, so I'm going to do something like this. Okay, so now I want you guys to tell me, is there's going to be also another tract, which is going to be the spinothalamic tract, which is going to be here somewhere. Okay, but just take my word for it. And there's going to be sympathetic tract also over here. But anyways, if you have this syndrome, okay, which is going to be on the left side, okay? If you have this that's cut, okay, what's findings will we see in this patient, which is a spinal trigeminal nucleus? Loss of pain and temperature, where? In the face. Is it going to be the left side or right side? Ipsi face, which is going to be the left side. Good. Because again, the trigeminal will take it from the ipsilateral side of the face. Now, if you have a cut of this one, which is going to be the spinal thalamic tract, where will you? What findings will you see in the patient? What sensations are lost? Good, excellent. So right-sided, pain and temperature loss. Good. The next thing is if you have the sympathetic fibers are damaged, okay? What will you see? Horner syndrome, left or right side? Same side, left side, excellent. Good. Last thing is you need to know the cranial nerve nuclei. Okay, so this one, the typical one that you really need to remember is the nucleus ambiguous. So I'm going to cut this now in the lateral medulla. So you'll have dysphagia. Excellent. Done. Okay, so that's the lateral medullary syndrome in a nutshell. You need to remember is you have loss of gag reflex because of the efferent arm, dysphagia, okay, and then you have, for example, difficulty speaking. You have also dysphagia, which is difficulty swallowing. You will have what else? You will have hoarseness, and now the uvula. Where will it deviate, left or right? Right side. Good. Perfect. So these are the findings that you're going to see with a lateral medullary syndrome. Okay, so now I'm going to go over the slides very fast, since you guys already know. The medial medullary syndrome now can happen due to two things. Okay, it's blood supply loss. So you'll have this one right here, which is going to be what supplies the median part of the medulla? Good. What supplies the lateral? Good. So again, the medial, okay, will be from the anterior spinal artery, some of the vertebral, not as much, no, not vertebral, basilar, some of the basilar, but the anterior spinal artery is the most important one you need to remember. And then from the lateral, it will be from pica, from the posterior inferior cerebellar artery. So again, this is basically occlusion for the medial medullary syndrome, and then it will lead to ipsilateral pyramidal, medial meniscus, and hypoglossal. So I explained all of this already. If it's bilateral, obviously you'll have quadriparesis because of both corticospinal tracts on both sides. So you'll have bilateral spastic paralysis. Bilateral lower motor neuron lesion of the lung, so of the tongue, sorry, not the lung, the tongue. So you'll have the tongue that's completely atrophied, okay? And then you'll have the complete loss of position of vibration sense because of the medial meniscus, okay? Is a medial medullary syndrome clear to you guys? Good. Lateral medullary syndrome. Now, lateral medullary syndrome happens due to, for example, loss of blood supply. So the posterior inferior cerebellar artery, some of the vertebral artery, as someone mentioned, but posterior inferior cerebellar is the most important one you need to remember. So you have spontaneous dissection of the vertebral artery. When does this happen? It happens mostly in neck manipulation. So that's just one thing it's a fact that you might want to know, or might not, it doesn't matter. So with neck manipulations, for example, with certain types of therapy and maneuvers, you might have certain movements of the neck that will cause spontaneous dissection of the vertebral artery, okay? You might have medullary neoplasms, okay? Cocaine abuse, abscess, demyelinating diseases, okay? That's for lateral medullary syndrome science, for the causes of it. What you need to remember with lateral medullary syndrome and the median is you need to know the blood supply. You need to know what tracts are affected. So in lateral, it's a wedge-shaped. That's why I drew it over here as well. It's a wedge-shaped infarction or wedge-shaped damage. It's going to affect ipsilateral facial hypogeusia and thermal anesthesia, basically loss of pain and temperature from the same side of the face because of the trigeminal spinal nucleus. And contralateral trunk and extremity hyperalgesia, basically loss of pain and temperature from the other side of the body because of the spinothalamic. Ipsilateral, palatal, pharyngeal, vocal cord paralysis, dysphagia, dysarthria because of nucleus ambiguous through the vagus nerve. Ipsilateral Horner syndrome, descending sympathetic fibers. You may have vertigo, nausea, and vomiting through the vestibular nuclei. It's not as important. Again, the reason why is because it might, the vestibular nucleus expands. Okay, so it might be in the pons as well. So it's not as important finding. The rest is very important. But if the question asks you and gives you all the rest of the signs, it asks you what other sign might you see, just put this one, okay? FCI cerebellar sign, I forgot to ask you guys this, but basically because of the inferior cerebellar peduncle, this inferior cerebellar peduncle will basically be over here. So it will go to the cerebellum. So if you have damage to this, you'll have cerebellar signs. So for example, ataxia. The other thing is the spinocerebellar tract. The spinocerebellar tract will also be lateral, as we mentioned in the rule 4. So because of this, you'll have also basically ataxia, okay? And occasionally hiccups and diplopia. This is because of the respiratory centers. In the medulla, basically you have all the respiratory centers and stuff like that. So because of if you have a damage in the lateral parts, because it's usually the respiratory centers and the main centers are around the nucleus ambiguous, okay? So if you have damage there, you might have, hiccups and stuff like that. It's not that important in the questions. Usually they'll ask you is what finding, for example, why do you have ipsilateral facial loss of pain and temperature and the main tracks that I mentioned to you guys, okay? Whether or not it's rostral or caudal medulla is not that important either, okay? Just know these tracks, know how to localize it, and know how to find lateral medulla. So now let's go over here and just apply the information before we go to the pons and midbrain, which will be much quicker, inshallah. So the 75-year-old man presents for evaluation of weakness. He reports that 2 hours ago, he suddenly was unable to move his left arm or leg. He denies any difficulty with speech. On examination, he can move all facial muscles normally. There's no ophthalmoplegia. On tongue protrusion, the tongue is deviated to the right. He is unable to detect lower or upper extremity vibration on the left. Can someone tell me where the lesion is? Okay. So, good. So, yes, this is a right medial medullary syndrome. Why is this the case? Firstly, look at the tongue. Okay, it's deviated to the right. That tells you that's number one, hypoglossal nerve. Next thing is he is unable to detect lower upper extremity vibration on the left. Okay, which is the medial meniscus on the right side. So it's a contralateral left side. Okay, and he's unable to move his left arm or leg. And this is the corticospinal tract. Okay. So it's left side because it's contralateral. So this is right medial medullary syndrome. This will tell you it's right. Okay. And these will tell you that it's contralateral. Is this clear to you guys? The medullary syndromes. Perfect. Now for the pontine and the midbrain, inshallah. Which will be very quick, inshallah. So in the pons, you need to know the basilar part of the pons and the tegmentum of the pons. But typically, with the pons defects, you need to know that if it affects the entire basilar pons or only it affects the ventral medial part of the pons, which is this part. That's the two syndromes in a nutshell. That's it. That's all you need to know in terms of the brainstem lesions and syndromes. So if you have, for example, affecting the entire basilar pons, okay, let's just say on the left side. Okay, so LR. So let's just say I cut all of this. Okay. Now, can someone tell me what happens if you have a defect? I'll underline the tract of this. Spastic paralysis, left or right? Right side is spastic paralysis. Okay, contralateral. Now, you have a defect in the fascicles, which is the part that's coming out of the abducens nerve. So, with the abducens nerve, what finding will you see with the patient? Exactly. Median eye deviation or he can't move it laterally, of the right or left eye? Left eye. Good. Now for the facial nerve. Where or what will happen with the patient? Exactly. Good. Will it be sparing the forehead? Yes or no? Good. Excellent. That's it. That's a concept. Okay. So this is one of the pontine lesions or the syndromes. Okay, which will affect the cortical spinal tract, which will lead to contralateral spastic paralysis. It will affect the abducens nerve, leading to ipsilateral medial. What's it called? Someone said it, which was correct. Medial strabismus, or you can't turn the eye laterally. Okay, that's the sign of abducens nerve. And for the facial nerve. Okay. You already said that the facial nerve is lower motor on the left. What other findings will you see at the patient with facial nerve palsy? Give me something with the ear. Loud, hyperacusis. Okay, good, because of the stapedius muscle. The other thing is the taste sensation from the anterior tooth, okay, through the chorda tympani branch. That's it, of the tongue. So these are the findings that you might see with the patient with this type of lesion in the pons. The other lesion is just going to spare the facial nerve. So it's the same exact thing. However, it's going to affect, for example, this part. Okay, so it's the left side and right side. So it'll have contralateral spastic paralysis, and then you'll have the ipsilateral medial strabismus, or you can't turn the left eye lateral. Done. Okay, these are the two pontine lesions in a nutshell. Okay, that's it. So the ventral pontine syndrome, which is the Millard-Gubler syndrome, it's a lesion of the ventrocaudal pons, which is basically the basis pontis, which is the basilar part of the pons, which is this entire thing. Okay, so it's this entire thing. So, and fascicles of cranial nerves 7 and cranial nerve 6. So the facial and the abducens nerve. So contralateral hemiplegia, spastic paralysis, ipsilateral lateral rectus with diplopia, ipsilateral peripheral facial paresis because of the facial nerve. Raymond syndrome is just sparing the seventh cranial nerve, and it's the ventral medial pons, affecting the abducens nerve and the cortical spinal tract. Okay, so leading to ipsilateral lateral rectus paresis, which is the abducens nerve, and then you'd have contralateral hemiplegia, sparing the face because of the facial nerve is normal. Okay, so that's pretty much the two pontine syndromes. There's one more, however, which is the locked-in syndrome is yeah, exactly. So here's one more, which is locked-in syndrome. Now, locked-in syndrome is basically the most common cause for locked-in syndrome is going to be central pontine myeloanalysis, which is basically this. A patient is hyponatremic, coming to the ER because of hyponatremia. Okay, so the patient is seizing. Okay, so with a patient who has hyponatremia, which is what they will, the finding is they're seizing, for example. Okay, or they have just mild hyponatremia. You don't need to know the thing I just said, which is the seizing part of it. Just know that the patient is hyponatremic, and what the mistake that the clinician did, for example, or anyone at the ER, is they're going to rapidly correct the sodium. So when you rapidly correct the sodium, for some reason, you'll lead to central pontine myeloanalysis, which is demyelination of the basilar part of the pons. So this will lead to this part, okay, which is the cortical spinal, cortical bulbar tracts are gone. Okay, so you'll have quadriplegia. Okay, you cannot move, you can't do anything. Okay, at all. The only thing that's spared is going to be the eye movements. That's what happens in locked-in syndrome. Okay, so it can, however, happen to other things because it's a bilateral ventral pontine lesion. Okay, so it's anything from the ventral pons. So it affects the facial nerve as well. So that's why you might have just complete loss of all facial movements except the eye. Okay, because of the midbrain. Midbrain is intact. So you'll have the oculomotor nerve is functional, the trochlear nerve is functional. So everything else is damaged. However, you have the patient that's fully awake. Why is the patient fully awake? Why is it not a true coma? It says on the slide. The reticular formation is intact. Okay, exactly. So that's pretty much the locked-in syndrome. Okay, so it's basically anything affecting the ventral pons. Most common thing is going to be the central pontine myeloanalysis. You might have an infarction of, for example, the basilar artery. tumor, trauma, hemorrhage, again, the basilar artery, and it will lead to quadriplegia because of the cortical tract, and you'll also have involvement of the facial nerve, okay? When the involvement of the facial nerve, have bilateral, paralysis of the face. So you can't move, you can't do anything at all. The only thing that is intact that the patient can do is the eye movements, and he's fully awake, okay? So he's not in a comatose state. All right, so that's pretty much locked-in syndrome, and that basically is all of the pontine lesions. Does anyone have any questions with the pontine lesions? All is good. I'm going to go to the midbrain now, and we're going to finish it off, inshallah, very soon. So now the midbrain. The midbrain, two lesions that you need to remember. Again, it's the same stuff. So one lesion, which will be basically this. Okay, and the other lesion, which will be this. Much it. Okay, so let's take it one by one. So now I'm going to do this side, which is on the right side. Okay. And I want you guys to tell me what happens. So since this whole thing is damaged, someone tell me what happens in the body, not in the face. Okay, someone summarize the whole thing, which is fair enough. But what happens to the body? Let's take one to the motor tract. Spastic paralysis. So you'll have left-sided spastic paralysis in the body. Okay. What happens with the face? With the facial muscles. Spastic. Okay. Why? Because of an upper motor lesion. Cortical bulbar tracts will go to the facial nerve. Will it be on the right side or left side? For the face, it will be the left side. Because an upper motor neuron, it will lead to contralateral lower 2/3 of the face. Okay. Only when you affect the pons, which is the facial nerve nucleus, and the facial nerve, will it be on the same side and the entire face. Okay. Is that clear for you guys? Yes. Okay. Good. So you'll have contralateral spastic paralysis of the 2/3 of the face and the whole side of the body. Okay, so it's like the whole distribution. The only thing that's spared is the forehead. Okay, so that's what you see with a midbrain cortical spinal cortical bulbar infarction of the crus cerebri. The other thing is the oculomotor nerve. So this is the right oculomotor nerve. So can someone tell me what happens to the left eye? To the left eye. And this lesion is on the right. No, nothing, exactly. So the right eye will look down and up. Okay. So that's this lesion done. Okay. So again, to recap what happens with this type of lesion, which is affecting the crus cerebri, and this is on the right side. So this is going to lead to contralateral spastic paralysis of the body, contralateral spastic paralysis of the lower 2/3 of the face, and it will lead to ipsilateral down and out eye. Okay, and loss of accommodation reflex and pupillary dilation. Is this clear to you guys? Cortical pontine tracts? I'm not too sure, honestly. I'm very sorry. I'm not too sure. But this is the most important things that you need to remember. No problem. Now for the next thing, which is the which is this, which is affecting the oculomotor and the red nucleus. So you have a damage to the red nucleus. What happens? Flexors affected. Okay, good. So just a concept that the rubrospinal tract, okay, the red nucleus, it's basically an extrapyramidal tract. It basically helps modulate certain muscular functions, which is the flexors. Okay, so that's one of them. The rest of it will be mentioned on this slide, which will be basically hemichorea, hemiatetosis, which is basically you're going to have a tremor. So the tremor in this case, intention tremor, is, for example, if you're trying to reach out for something, for example, I'm going to reach out to this bottle, I'm going to have a tremor trying to reach out for it. Okay. However, resting will be normal. So resting, for example, I'm going to be like this. I don't have a tremor. However, if I'm trying to reach out for an object, I'm going to have a tremor. Okay, so that's what intention tremor is. So basically, the involuntary movements will be affected with the red nucleus. So that's pretty much it. I'm not sure about the rest, honestly. But basically, you will have involuntary movements that will be present with the red nucleus, okay? Infarction, or a red nucleus affected. And the oculomotor nerve. And that's for Benedict. If it's for the Weber syndrome, which is going to be the crus cerebri, or the cerebral peduncles, it will affect the corticospinal, cortical bulbar, and also will be the oculomotor nerve. So you'll have the contralateral hemiplegia, including a lower face, and you'll have ipsilateral oculomotor paresis plus parasympathetic cranial nerve 3, which is going to be the accommodation reflex, and the dilation of the pupils are gone. Are these two clear for you guys? And these conclude the midbrain syndromes. Cool. Now, last 3 slides, which will be questions. A patient complains that he cannot move his right eye to the right, and that his right side of his face is expressionless. Which of the following is likely locus of the lesion? This is a trick question. Someone answered D. How about the rest of you? Someone said C and someone said E. Okay, so first thing is, it is the pons. Why is this the pons? Firstly, just look at he cannot move his right eye to the right. So this right eye can't move rightwards, meaning that he can't turn his right eye laterally. So this is abducens nerve, pons, immediately. His right side of the face is expressionless, meaning that this is affecting the facial nerve. Now, where is the facial nerve? Is it ventromedial? Will the fascicles of the facial nerve be in the ventromedial pons? No, it's more laterally. Okay, so it's a dorsal pons. So the answer is C. Okay, why is it the dorsal pons? Because the nucleus of the facial nerve is in the dorsal of the pons. Okay, and the abducens nerve. There's no cortical spinal tract defect in this patient. Do you see how you can apply the info? It's just like this. Okay, so yeah, pretty much it's the dorsal pons because it's affecting the facial nerve and the abducens nerve. Is this clear to everyone? Okay. Why is it not the midbrain? What would you see in midbrain lesions? Lateral eye, down and out eye. Good. And why is it not the medulla? Okay, sure. I can go back to the pons. So in the pons, which is this, you can see that the dorsum of the pons, which is this one, is the dorsal side. You'll have the facial nerve. Okay. The facial nerve and the abducens nerve. So even if you have it affecting here, the facial nerve, once the fibers come out of the facial nerve nuclei, it will go around it to form the facial colliculus, and then will go out. So anything affecting the dorsum of the pons will affect the abducens nerve and the facial nerve. Do you see how it causes these symptoms? Yes, no problem. So that's done. So it is C. Okay. Now, a 64-year-old woman is admitted to the emergency room after she experienced dizziness. Several days later, a neurological examination reveals that the patient was unable to move her right eye immediately. Which of the following is a likely locus of the lesion? Good. Perfect. It's E. Okay. Why is it E? Perfect. Excellent. It's the oculomotor nerve. Last question. A 72-year-old male, I think so, actually, Tasneem. Yes, probably. But I don't think it's very important that you need to know that. The most important thing is knowing the cranial nerves, the tracks, and then how you can localize where you are in the brainstem from those signs. That's pretty much all you need to know for a brainstem. And then if they ask you in medial medullary syndrome, they'll give you 3 signs. You have to know what the 4th one is. Okay, stuff like that. So, for example, just to mention in words, it's for example, if a patient comes to you with the right-sided right-sided spastic process, right-sided loss of vibration and proprioception, and also, and yeah, that's it. What other findings can you see? Okay, if it's in the medulla. MLF is affected, and not dysphagia. One more thing. Tongue. Good, that's it. So that's how they tell you or ask you sometimes. Last question. A 72-year-old male experiences difficulty in walking downstairs and reports some double vision as well. In this instance, which of the following is the most likely locus of the lesion? D, midbrain. Why? Exactly. The trochlear nerve. Okay. And that concludes our session. Do any of you have any questions? No problem. I'll send the PowerPoint, don't worry. No problem. Of course, anytime. If you guys have any other questions that you need in neuro in general, you can text me or contact me. My email and my phone number is in the beginning of the PowerPoint. You can go through it. Okay. The graphs, these graphs, I'm guessing these ones, right? These are from AMBOSS. Okay, so you can go through AMBOSS and each section from the brainstem will have it. Do we need to be able to identify the tracks on the cross sections? You may be having like 1 or 2 questions where they give you the cross section and you need to know where the tracks are. Okay, so yes, but for this, just apply the rule of 4 and you will be able to find it, inshallah. I think so, yes. Or they might be a bit more clear. I hope it's clear. Because I know the lecture ones are not that clear. Okay. So if you have any more questions, feel free to text me, to email me, anything. Okay. Anything in neuro in general. Inshallah, I'll be able to help. And thank you guys so much. Have a great day.